Good morning, everyone. This is Tuesday, the 25th of October 2022, and this is our annual report session for the Department of Health. Honourable members, Minister, HOD, all departmental officials, a warm welcome to you this morning. If we have guests online, I suspect we will still have guests joining us in chambers, but we need to get going since we always have an issue with time when it comes to health matters. So a warm welcome to you, and we all look forward to the department to report on the developments that has taken place for the year under review 2021 to 31 March 2022. I will now afford members the opportunity to kindly introduce themselves. My name is Wendy Kaiser-Philander and I chair the Standing Committee for Health.
Thank you, Chairperson. Good morning, Chair. Good morning, everyone. My name is Rachel van Vogel.
Good morning, all. Dan Plato.
Good morning, Chair. Good morning, Minister, the department. My name is Ayanda Barnes.
Thank you very much, members in chambers. We have an apology from Honourable Fry, and Honourable Baartman is standing in for him this morning, and she's joining us online. Member Baartman, for the record, that we can just hear that it is you and not someone else.
Good morning, Deirdre Baartman, standing in for Member Fry.
Much appreciated. Thank you, Member Baartman. I will then start with the Minister.
Good morning, all. I'm Noma French Mbombo, the MEC for Health.
Good morning, everyone. Keith Kluti, the Head of Department.
Good morning, Chair and members. My name is Anda Ngosi, Chief Director, Strategy. Thank you.
Morning, Chair and members. Sadiq Karim, Chief of Operations.
Morning, Chair and members. Simon Kay, Corporate Support Services Department.
Morning, everybody. Leslie Shand, Data Management and Governance.
Good morning, Chair and members. Melvin Moodley, Director, Health Intelligence.
Good morning, everyone. Glenn Carrick, Acting Chief Director, Finance.
Good morning. Santi Roy, Director, Supply Chain Sourcing.
Morning, everybody. Ronel Gous, Director, Supply Chain Governance.
Good morning, everybody. I'm Laura Angeliti Dutwe, Chief Director, Facility Infrastructure Management.
Morning, Chairperson and members and colleagues. Bernadette Aris, People Management.
Good morning, colleagues. Anita Pabu, Chief Director and CEO of Red Cross Children's Hospital.
Good morning. I'm Doug Newman, Head of Ministry.
Thank you very much, and that is the entire team. We do not see any. Oh, at the back. I'm so sorry. Please go ahead.
Glenys Denica, Health Intelligence.
Good morning, all. Andre Luck, People Development.
Good morning, all. Peter Smith, People Management.
You can move closer to the microphone, please. Thank you.
Good morning, all. Rafika Isaacs, Strategy.
Good morning, all. Ashley Levendal, Health Intelligence.
Morning, everybody. Liesl Kloon, Naib Auditor General.
Thank you very much, and a warm welcome once again. I do not see any members of the public online or in chambers, but we'll ask them to introduce themselves once they arrive. Honourable members, as mentioned, we will. Member Van Vogel.
My sincere apologies. I just received a message from Member Bakufos. He's not feeling well.
Thank you very much, and we wish her a speedy recovery. Thank you, Member Van Vogel. So, members, today we will speak to the annual report that monitors the department's performance for the 2021-22 financial year against the predetermined annual targets as was outlined in the 2021-22 annual performance plan. Honourable members, I will now afford the opportunity to the Minister for 5 minutes of introductory remarks, after which, immediately after that, if the HOD wish to add anything, you're most welcome to do so. Minister?
Thank you, Chair. Because I know that with the annual report, it's a whole day thing, and we might still be deliberating, probably even in one page. So I won't be long, but I just want to thank the department for, I see everyone is almost here, for being here, and also for the members to be here. But generally, the current budget year, financial year that you are discussing, is the year when we was hit hardest by 2 waves. It's also a year of the vaccination. It's a year of trying to reintegrate services where everyone now comes back. It's no longer about stay home. We're busy with the COVID. It's also a year when we actually felt the system shock after COVID, and also with all other illnesses like the mental health and everything. It's also about the year where, because we're coming from the COVID, where we had the whole procurement system where we have to do the PPEs and all of those. But for us now, it was about when we have to bring all other stuff. And lastly, it's about when we piggyback on some of the lessons learned when we had the biggest hospital built within a month, but now we have to convert it to the vaccination sites, and the vaccination sites also through the drive-thrus and all of those. But also it's the year when now we had to recover and the journey to recover, because it is the time that we realize that we have lost as many, and some of them are still even living with a long COVID, and I'm talking about our staff. So this is the one of the saddest years, as it was in 2020, but at least there have been lessons learned from the 2020. Thank you, Chair.
Thank you very much, Minister. HOD?
Thank you very much, Chairperson. As indicated by the Minister, April 21 to March 22 represented the year where the third wave played itself out in July 21, June, July. It was the most severe wave of the 3 waves up to then. The 4th wave in December was when Omicron was announced to the world, and we had a November-December spike of cases, but the first time a dissociation of admissions and deaths. And then in that time, we went over 4 million, over 5 million vaccinations in this province. So it's a year of great celebration and recognition of the staff, because that would have been coming out of 24 months of dealing with COVID, going on to 30 months, or 24 months would have been the period that we end, and would have entered the post-COVID era, so to say, from the 1st of April 2022. In this time, we recognize that we've lost additional staff members, and therefore the staff that we have is the staff that has come through 24 months of COVID. And as the Minister said, they moved from, in the first year, losing quite a significant amount of fellow staff members, going into this year that's under review, still doing COVID, doing vaccinations, and preparing for everything else that returned. And while we were all doing those things, we achieved the 4th clean audit in a row. So what we do here today, and you see that there's quite a big team of people here with us, we give recognition to the achievements that you see in this book, the recognition of many staff members' hard work and toil. So we do this in recognition of our own staff, and specifically the staff we lost in service during this period of time. So thank you very much.
Thank you very much. HOD, indeed commendable. Members, we will now immediately go over to the business of the day, as we will be dealing with Part A. Members would have seen that Part A contains the general information, which includes the forward from the Minister as well as the report of the Accounting Officer. So from pages 8 to 24, page 8 to page 24 deals with Part A. Members, can I ask for, I'm not sure how many members of the public will be in attendance, but since this is a public hearing as well, we would want to grant the opportunity for members of the public to pose their questions on specific pages contained within this report as well. And I wish to ask members from the onset that we kindly stick to the annual report. I know there's sometimes, partykeer is daar 'n lang aanloop na die vraag, but please try to keep your question to the point and kindly indicate clearly to which page you are referring to. So for the sake of time as well, I don't want to rush you. I want us to really thoroughly interrogate the report, but let's start by affording members on Part A 2 questions per member. Then we will come back to your follow-up, and then we will take another round. Let's see how best we can manage our time in that instance. Honourable Plato, I see your hand.
Chairperson, thank you very much. At the beginning, I don't want to immediately ask a question and that sort of thing. Listening to the Honourable Minister and the Honourable HOD as Accounting Officer, I think I want to start off by congratulating the department. You know, we can ask an awful lot of questions, but omit very important issues, and your unqualified audit without findings is a highlight during trying times, during COVID, and during many, many issues also in your department itself. I think, let me say that there's a lot of congratulations one can give. I would love to do that as well. But Chairperson, just allow me to say, when I read the 2 forwards and read it again and saying to myself, I don't know how you have get it right during these difficult times to get a good audit finding, but also to deal with COVID and the 2 waves and the possibility of another one and that sort of thing. But also you refer a lot to your staff, and I think that's for me a highlight. Looking at what the staff had to go through, you referred to the death and then another set of death, 52 people in your last category you raise, and I couldn't help looking at your quotes, to quote you out of your forward. Our story in 2021 is not one of despair, but rather one of resilience, character, and hope. And I think that for us as politicians is very important. We need to recognize that. But you also said the health system was pushed to its brink. And I think that for me is another important issue. Despite every hit that the system took, we kept moving forward. And Chairperson, sorry for me to mention that, because for me that is very important issues out of the HOD's forward. You also said at the same time your people had to deal with personal risk of contracting COVID-19, the fear. And the fear was there because the question was who will be the next one in line. Even if you're a nurse or if you're a medical doctor, you're still just a human being, if I can put it to you like that, and nothing else. And I note you lost 150 staff and the intentional grieving you had to deal with and that sort of thing. I don't know how that other comment is, despite the risk, your health workers never faltered. I couldn't help reading that correctly as well. And they rose to meet the challenge, to care for those who needed it most. So to all of you, from a political point of view, I need to say to all of you as a bunch of health practitioners, thank you very much for what you have done for the Western Cape as a whole. Thank you, Chairperson.
Thank you very much, Honourable Plato, and I think we can certainly not deny the fact, and we echo the sentiments indeed. I just want to ask to the gentleman in the gallery. Good morning, sir. Will you be making a contribution? Can you? Okay. Can you please find your way down then to be close to a mic? Thank you very much. And then, honourable members and department, we do have some guests that joined us. Good morning to you and a warm welcome. Do you mind please just introducing yourself for the record, please?
Good morning, honorable members. My name is Nolufefe Mbombo from the area of Atlantis. I'm concerned about the budget speech. The budget, what do you call it?
Annual report.
Annual report. I'm just concerned about the area of Atlantis. Thank you very much.
Thank you very much for being here this morning, ma'am.
Good morning, everybody. Honorable MEC, my name is Nosipo Daniels from the area Langa.
Warm welcome to you as well.
Good mornings, everybody. The name is Graham Lindos. I'm from the Tigerwork Sub-District Health Forum, and I'm here to have some inputs in terms of the report of today.
Thank you very much, sir, for being here. Honourable members, Member Van Vogel, I recognize you.
Thank you, Chairperson. Chair, allow me to congratulate the HOD and the Minister and the Department for the positive audit opinion. So yeah, thanks for at least some good news. My concern is the TB remains the leading infectious disease killer in the world. And our country and province continues to be amongst countries seriously affected by TB. And it is a cause for serious concern that the forward of the MEC and the accounting officer report don't give this killer virus the attention it deserves. Are there any reason for this? Then secondly, previously the minister mentioned that there was no cost involved in the name change of the department. But I really need to understand if there was no cost.
Honourable Van Vogel, may I ask, are you on the forward of the minister?
Yeah, on the forward.
Okay.
That's why I'm asking. It's TB, there's nothing in the forward, so I'm still there. Yes. So then, secondly, in terms of, as he mentioned, the minister mentioned there was no cost involved. It's difficult for me to understand because we know you have to change letterheads, the boards. Is it that there's really no cost involved? I really want to get an answer on that. Then on page 8. On the MEC's, the forward of the MEC.
Can I just ask for clarity? You said that you're on page 8, the forward of the minister. Are you also saying that why is the report omissive of the name change and the cost involved? Is that your question?
Yeah.
We're dealing now with 1 April 2021.
Part A5. Part A5.
Which page, member?
It's page 5.
Page 5.
Yeah.
We are now dealing with pages 8 to 24.
The name change is most on part 8, the first page, member, in your. That's where I am referring to. It's your part, page 5 in your annual report. So it's still part of the pages covered, according to me. Okay. No, I understand that. But I know the minister do have an answer for me.
No, we'll only stick to the period under review, member. Thank you.
Yeah, then my first question then, of the second question then on page 8, I love to ask this question, and I think the minister is going to get angry with me, but I want to know from her, does she believe the department could have handled the outbreak better? And did she commit any grave mistakes, and what lessons have been learned from them? Then on the last paragraph, also page 8, for me, the pandemic exposed and widened the inequalities in health. And the poor were vulnerable, and there were too few vaccination sites in areas like Mitchell's Plain, for instance. Why was it the case? To what extent did it contribute towards low vaccine rate, and what measures were put in place to address this? Thank you, Chair.
Thank you very much, Honourable Van Vogel. Member Barnes.
Thank you, Chair. Chair, my question is on page 11, under program expenditure, where the department recorded an under expenditure. My question is, while it is understandable that 273 million is a small amount compared to 28 billion, but it remains a huge amount. So what are the reasons for this under expenditure? When did the department pick up the possibility of underspending? And what action plans are there to prevent the underspending? My second question attached to the same question, Chair, is with regards to spending program 2, we know that hospitals such as KDH have been allowed to overspend the budget to address service pressures. How is this reflected on the program expenditure, seeing that there is no overspending? My second question, Chair, will be on number 12, page 12, unauthorized, fruitless, and wasteful expenditure. An amount has been incurred there. I want to know, Chair, is that what are the details of this fruitless expenditure and wasteful expenditure, and how many incidents were involved, and whether disciplinary actions were taken to the incident? I thank you, Chair.
Thank you, Member Barnes. Minister, between yourself and the HOD, you can answer or refer to the appropriate program managers. Just before you continue, we have 2 additional guests. Can I please ask that you introduce yourself for the record?
Good morning, Damaris Kiewicz.
Good morning, Ms. Kiewicz, and welcome.
Unknown to the House.
Thank you for being here.
Good morning, everyone. My name,
Thank you. Good morning and welcome. Good morning, Mr. Karels, and welcome. You may proceed, Minister.
Thank you. I think it's one question that is related to specifically, that is general, from Member Van Vogel. But you are asking a relevant question. I cannot be met with you. It is a relevant question. It's about how would we have probably have had it differently. I think for me, it's about lessons learned, taking forward. One is about having a pandemic that actually exposes so many cracks in the health system generally. Health system, whether it's in the national or wherever, it exposes us how fragile our health systems has been. Up to that, we have to put on hold other illnesses that we go on holiday, TB, go on holiday, diabetes, we are busy with a pandemic. So lessons learned for me that we shouldn't be having such an illness or a virus that could put so much pause on other illnesses. However, because it was a new virus, even where it started from, it was still a work in progress in terms of learning. It was difficult for South Africa to transplant and take over some of the research evidence that has been elsewhere. You will recall when it started into China and then went to the other countries. In terms of how it mutated itself in Europe, we saw what it did in Italy, we saw what it did in Spain, and how it did in America. And the lessons learned was about that it has not, or it's not only about the virus as an agent, but it is also about the population and the environment. Therefore, it was difficult for us just to take things as they are. It meant that we have to keep on and in terms of keep on learning lessons. And also, let's learn this about you don't need to have 3 months in advance planning meetings. Let's go and talk about, it was about within an hour. We just had a meeting with the HOD or with the premier, with the team, and then think, okay, everything is right. And then within an hour, 30 minutes, about things have changed completely. Let's regroup, where we just put on techies and then relax and have a cup of coffee, whether it's virtual and whatever. So it's part of the lessons learned. Lastly, because I don't want to talk too much about it, lessons learned is about that as a South African health system, we didn't consider the social determinants of health. We kept on, it's there on the books everywhere, we kept on talking about them. But the issues of the poverty, the three challenges, poverty, inequality, unemployment, that has impacted on health. Because we kept on thinking that we have got this, forgetting that health is everybody's business. I remember some questions where you say, Minister, what are you doing in Khayelitsha, where we've got COVID now, and people cannot be able to social distance. I mean, you can't social distance in a shack when you are 15 of you. Where are you going to get 1.5 meter when the shack is 2 meters? But the issue it was about, it was directed to us as if it's our fault. Like the question about in some rural areas, in the farming communities, where normally it's once a week, mobile clinic, and then we have to have vaccines. But that Auntie Sarah only knows a mobile clinic that comes on a Wednesday. Even if you bring vaccines on a Monday, they won't be there. Because for them, they will know on their boom is on Woensdag at 8 o'clock. That's it. Therefore, you have to accommodate, like the situation where we have halls that they were never utilized even before, have to take them there. It was about where that let's regroup. If we are going to do Lanesburg, in those 16 whatever farms, if they are used to Wednesday, let's bring it on Wednesday. Otherwise, you will never get them. So it's some of the lessons learned. And then lastly, it's about there's no health system without health workers. You like it or not, you might have the best hospital, you must have the best whatever, but if there are no health workers, you have nothing. So when we have our staff dying during that time, especially in that December 2020. I think at the time when we realized the third week, it was about already 40, I think 40 that were, in as much as that we have got 33,000 plus health workers. But it hit home when we were at our worst moments. And it was about the faces. It was no longer about case A or case B, according to the system. It was about chief director so-and-so. It was sister so-and-so. It was security so-and-so. It was an EM so-and-so. That's when we realized that we are humans too. We bleed the same color, and we are like everyone else. We are vulnerable. So that's some of the lessons learned. Doing differently, I don't know, because the issue is about it. We're facing a virus that nobody knew about it. But thank you to our researchers and the scientists who kept on even feeding, not onto the South African health system, to the whole world of science in terms of the lessons learned. Thank you, sir. Over to you.
Thank you, Minister. HOD.
Thank you very much, Chairperson. To Member Windvogel's question about TB specifically. So, Member Windvogel, we take your point. In the 4th paragraph, we refer to the fact that during this period, we almost had to put everything else on hold because of dealing with the 3rd and the 4th wave and having to vaccinate everyone so that we don't have future waves with multiple deaths, including healthcare workers. And then in paragraph 4, all we say is this had a cost on the rest of the healthcare system. We don't specifically mention TB or HIV or diabetes or child health or maternal health or any of the other conditions. It is a general statement that everything else was taken a backseat on it. The extent to which it took a backseat became clear to us after the 1st of April. So in this year that we're in now, which is the next reporting period, there's a very, very strong focus on everything that was, in a sense, put on the back burner by necessity by COVID. But we take your point that TB is one of those key important aspects. And in next year's annual report, we will be very clearly articulating what has happened, and quite a few things have happened. Actually, just before the end of March, which is not in the forward, the Premier did announce on the Provincial AIDS and TB Council, so it is still in the reporting year, that there is an emergency for TB, which we subsequent to April did something about. So that will be the reporting on it. In terms of the name change, I think we did answer that the name change in this reporting period did not happen in the reporting period. And in next year's reporting period, there will be a full engagement around the name change. In terms of the lessons learned, just to add to Minister Mbombo, I think one of the biggest things is that having a pandemic, and this is a global experience, so we are part of the global experience. Having a pandemic, it humbles not only a healthcare system, it humbled society. Because the lesson is that society was not ready for it. And that was society globally was not ready for it. Healthcare systems globally, as part of society, was not ready for it. So the biggest lesson actually is be ready. And what we've learned, this generation, because you remember the last generation that did this was in 1918. They long gone, that generation. 1948 was almost there, but not as bad as this one. That this generation has learned one thing, and that's why we make the point about resilience. Be ready for anything at any time. That's the biggest lesson. And then just lastly, the vaccine sites that you ask about. The phenomenon in Mitchell's Plain, which is exactly the point that you're raising, is for Mitchell's Plain had the site from the outset that produced the most vaccinations of any site across the province. The uptake of residents of Mitchell's Plain at the site in their own neighborhood was low. That is what happened. People drove from Sea Point to go to the Mitchell's Plain site to get their vaccinations. And in there was a big lesson. So it's not that we underprovided access in Mitchell's Plain. There were other factors that were holding the people of Mitchell's Plain back for coming for vaccination. The same pattern repeated itself in Khayelitsha. The same pattern repeated itself in Central Karoo. And those factors we know now is that the power of social media, the power of misinformation, trumped our power to convince people that this is in their best interest. So that is just to put that picture in context. Member Barnes' questions. I will ask Mr. Kay to explain the under expenditure, but you will hear that it's partly very intentional why we did it. And then he will explain later in the document, there's a very detailed breakdown of that 273 million. And just to explain to you, Khayelitsha Hospital's over expenditure is within Program 2. And what we do there is we allow certain hospitals with pressure to overspend while others underspend. And the balance of that is a break even for Program 2. If you then look at the fruitless expenditure, which is 12,000 Rand, I'll also ask Mr. Kay just to reflect on that. Thank you.
Thank you, HOD. Yeah, well, I think we'll probably go into the under expenditure quite a bit in this afternoon within the scope of, but let me just give a basic premise. We never fully understood what our costs were going to be when it came to COVID. And as luck would have it, our testing was lower than the budget that we required. And so we had about 60 million rands worth of saving from testing, which we then asked to move into the following year. So we were using our savings from this year to push into the following year, because once again, we didn't know come March whether we were going to have further and additional waves that came through. The other thing that was also a bit of a deferral was on the medico-legal. There were fewer cases that were finalized in last year, but some of those cases have now come through to this year. So once again, it's a timing difference. It's about having budget and anticipating that that would be spent in the previous year. It wasn't, and therefore we'll move the budget to this current year where the expenditure has actually been incurred. I think Dr. Kluti has answered the question around Khayelitsha, but I mean, we are permitted within terms of Section 43 to take savings and to shift and via those to where there are certain pressures within the system, and that's what we do. We do that on an annual basis to avoid unauthorized expenditure, and so that's what we've done in that instance. And then the other two major areas was around bursaries and education, because we must remember that, again, we were in a very disruptive educational cycle. So students weren't able to complete, they weren't being able to register. So there was kind of a hiatus in terms of issuing out bursaries. Again, it's a timing difference because of where we find ourselves within COVID. And then the last thing was around infrastructure and facilities. Again, we must remember where our focus was. We were rolling out vaccination sites everywhere. And the same way there were some services that have had to be reprioritized. There were infrastructure and maintenance projects that ultimately needed to be reprioritized because our focuses were in other places. And once again, we take that expenditure. It's not like it is not going to be incurred. It is the impact of COVID that has pushed it into this following financial year where we are doing that. But again, the lists of the infrastructure projects are provided in a great deal of detail elsewhere within the annual report, which we can have a look at. On the fruitless and wasteful expenditure, it's 3 occurrences totaling 12,000 rand, and if we go to page 259. I think 259, the details are provided within that. And again, with fruitless and wasteful, as with irregular expenditure, there is a process. Each transaction must be looked at, and there are circumstances that are then applied, and then the appropriate consequence management is then meted out, whether that is a recovery, whether that is corrective. It all depends on what the case is, and the same thing holds true for irregular expenditure. Let me leave it there. Thank you, Chairperson.
Thank you very much, Mr. Kay. You may enter, sir. A warm welcome to you, sir. Will you kindly introduce yourself for the record, please?
Good morning, everybody. I'm sorry I'm late. I'm Leslie Andrew Sylvester, and I'm from the health cluster of Heideveld and Menenberg.
You're most welcome, sir, and thank you for being here this morning. And another member in front.
Morning, Chair. Apologies for being late. Member of the committee.
Thank you very much, Member Tejo, and you're most welcome as well. Thank you very much, members. I'm not going to go on to my question because that basically latches on to what Member Vogel asked in terms of lessons learned. And I think in the next report, we will see how these lessons learned have impacted on the department's strategic objectives going forward. So I'll settle with that for now. HOD, just to be clear, you said 4 clean audits, but for this year on review, 3 and now another one.
I think the cycle that the Auditor General reports on is normally a 3-year cycle.
Okay.
But this is, if you take the rolling, it's out of the 3-year cycle. There was a 4th clean audit in the previous 3-year cycle. So this is the 4th one.
I see.
So it's 3 reported on, and the 4th one is the last one of the previous 3-year cycle.
I see. Thank you. That makes sense. Members, emanating from your previous questions, do you have any follow-ups? Are you happy that your questions are answered? Member Barnes, I see your hand. You may proceed.
Thank you, Chair. Maybe just one follow-up on my question on unauthorized expenditure. I get the explanation where it is mentioned that it depends on different cases how it is handled, but for where I'm sitting, I don't understand how it gets recovered. If maybe the department can just give me an example, because I'm not there. I hear that we recover after fruitless expenditure. What's the process? How do you recover? Where do you take? Because I'm not there. I don't understand. If I can just be clarified on that. Thank you, Chair.
Thank you, Member Barnes. Member Van Vogel, you have a follow-up? You're covered. Thank you. Actually,
Thank you, Chairperson. I'll ask Mr. Glenn Carrick to answer us. Glenn, sorry about that. Mr. Carrick will give you an indication of what the claim back process is. Thank you. Over, Glenn.
Thank you, HOD. Okay, so in these cases, so once they assess it, they first determine, is there a possibility of recovery from the supplier? So if I refer, and I don't want to go into too much detail, but if I look at two of them, PPE invoiced but not received, and then payment for printed trays that was included in the quote. So the first point of call would there, because we've got a standing relationship with suppliers, would be to go there and say, look, an error was made here, and we would. My first port of call would be to request a credit note from those suppliers or future purchases that we would be doing in this current financial year. If that is not forthcoming for whatever reason, then we'd look at the actual instance and see, was there any negligence involved? Now, most of the cases, if you take the amount of transactions we do during the year, and it is unfortunate with human error, there is chances of things like that happening. So it's only in the case of real negligence that we would then go to the point of call of trying to recover those funds from the official that was found to have been negligent in that case. I hope that answers your question. Thank you.
You happy, Member Barnes? Thank you very much. Honourable members, we move along to Part B, pages 27 to 121.
Chairperson, when you started, you were saying we are taking 2 or 3
okay,
questions.
you have another question on Part A.
Yes.
How many questions do you still have on Part A, Member?
I have 3, Chair.
Okay, then we conclude with Part A. Please proceed, Member.
Thank you, Chairperson. On the Accounting Officer's report, Chair, page 9, the third bullet, for me, this number continues to show how important community health workers is. Community health care workers is to our system. And over the past few years, these workers have protested outside our building to demand better working conditions and remuneration. What has the department done to meet their demands and address their grievances? And secondly, given the funds that the department transferred to NGOs of NPOs for community health workers, programs of activities, is there any conditions attached to these funds? And how much is allocated for salaries? Then, Chairperson, also on page 9, bullet 4, given the identified need for a regional hospital in the Klipfontein area, which will cater for Khayelitsha and Mitchells Plain, wouldn't it be beneficial to convert one of the 2 district hospitals into a regional hospital? And if so, how long does such process take and what does it entail? And then lastly, Chair, in terms of the backlog, do we still have backlog? And how many? Thank you, Chair.
Julie, or Minister?
On page 8, remember you mentioned earlier that you park certain type of services because of COVID-19. Do you have a backlog on and numbers? Can you provide numbers in terms of those backlogs? General, yeah, Chair. Thanks.
Minister?
The HOD will respond on the specifics, but I think I need to give a context of the community health workers because it's one of my favorite subjects. When in 2012, I'm putting generally, and then the HO will do the specifics because sometimes the health system, it's quite complex. In 2012, when the phase 1 of the pilot of NHI was initiated, because according to the National Health, NHI, they're putting, I think, in 3 phases. So phase 1, which was started in 2012, to take 1 district per province. I'm aware Eastern Cape, I think, and KZN asked for additional, but from their own pockets. Part of the, I think there were 10, part of the 10 of the pillars of the pilot to be part of those districts was what we call ward-based outreach teams, which is community health workers is part of. It's a system that was borrowed from Brazil. At the time, I was the consultant for the National Department of Health, so that's why I'm passionate about it. So that was part of it. But what the National Health didn't do was to make it sure that whether there is a money followed, whether in regard to they become part of the PESAL, or they also become part of the NGOs or whatever, and also even follow up with the grant. They've never done it. So it has always been a pilot. When then National Minister Motsoaledi came up with an announcement, I think it was based on the bargaining council, the National Bargaining Council, about their resolution, resolution 1 of the Bargaining Council 18, when now it was about, based on that, at least the issue of the remuneration needs to be reviewed. So that part of it ended up reviewed, plus also in terms of the hours. So which is for us, we also follow suit. But now where things are, if you look at all across the provinces, what Gauteng did, and also partly KZN, was about to put them as part of the PESAL, like when you see the number of health workers, healthcare workers, they are part of it. Unfortunately, that was found not to have follow the processes. I think the Eastern Cape also put some of them, like there's a thing that called abnormal PESALs, like you put some code next to the PESAL, Mbombo 555, whatever, then you put the abnormal code, which is just for the processes to happen, which is all now they found that they were not supposed to have followed that, because the issue is about one has to standardize the training. Some of the healthcare workers, they will have had standard 4 or grade or metric, others and so forth. And also in terms of the training, it was never been the same throughout, because we just adopted the Brazil model without necessarily looking at that. And also even there were those, because at the time of the salary, those ones whom we put part of the system during the HIV/AIDS, which are counselors who are in the HIV counselors who are actually inside the facilities as early as 1980s. So there was never any process of trying to standardize it. That's why even up to now, sadly, they are like that. Now, with the Western Cape 2015, we had a summit, a community-based, community and health workers-based summit, where we have to come up with a strategy, because it means that we are all by ourselves, because no one is doing the same thing. So that's when we adopted that they are part of the health system, and they need to strengthen the primary health care system, where its pillars, it talks about public participation and intersectoral collaboration. Therefore, the NGOs and the civil society that have been participating in the health system, they need to be part of that. And also the government doesn't train health workers, because they are being trained anyway by the NGOs through these processes of the health and welfare sector, SITA, whatever, all of those. Therefore, that needs to continue until the national government come up with a strategy. Because if you look even in the current human resource for health, you'll find that there's nothing that talks about them there clearly. So the last one now, beginning of the year, which Dr. Cruz is going to take over and mention that where we are now, it was about reviewing, because everyone was you saw also in the city, I mean in Joburg, and also in the Gauteng and others where also they've been totoing. Here in the Western Cape, the issue is about we continued as it was in regard to that the civil society, the NGOs who have been training them, who have been appointing them, continue. And therefore, but instead of now doing the calling for the service provider on annual basis, we just give it for 3 years, and then we source them from them. But the processes in terms of where they to be allocated and that they are part of the system, which we saw, they help us during the community screening for COVID. They helped us in terms of the vaccination. They're even helping us in terms, especially with the mother and child, they are part of the health system, in as much as that the service providers, the NGOs. So recently, I'm not sure, 3 or 4 months ago, it was one of the items on the agenda, part of the National Health Council, where now the country is going forward in terms of taking them forward. So over to you now, that part.
The Minister, HOD.
Thank you, Chairperson. Thank you, Minister. So, Member Van Vogel, as Minister described, the current situation is that there is no standardization across the country. So the current National Health Council recommendation is that the issue that you raise has now been registered that it is a national issue, and in each province you will have the satisfaction until you have one national dispensation. So the current position is that whatever it is that is in every province, the remuneration must be standardized. So all community health workers get the same remuneration across the country. That's the first thing. The second thing is that there is a national training standard that everybody now needs to adhere to. The third thing is that all the conditions which is not standardized, there must be an attempt to bring it to some kind of uniformity. But based on the third aspect, and it's linked to the others, what never happened and what should have happened in hindsight is the department and the national minister should have approached the Minister of Labour and should have asked for a specific sectoral dispensation for community health workers. Because then the Department of Labour minister pronounces on it and says, this is the dispensation for all community health workers in the country. So that has been explored. There's technical work now between the National Department of Health and Labour, and the process is now starting. So we're all waiting for the sectoral determination and then standardization for the country. In terms of your question, Dr. Karim and his team are meeting all the NPOs tomorrow, actually. And what they do in this is to bring this update for everyone. And what we have, which is actually quite rigorous in our province, because we've built on it over more than 10 to 15 years on this, is that the contracts are actually very rigorous. It is very prescriptive what the money is for, that the money gets transferred. Therefore, the remuneration is very clearly articulated which each community health worker should get. We also are very clear on a admin fee, a uniform fee, a transport fee, all of those aspects. So what will be tomorrow, again, is just to reiterate that the contracts is standardized. Community health workers should, and it's very prescriptive if you read the contract, what the money is for, so that we can have standardization in the province. And obviously, we will articulate this very clearly and work with the national process towards standardization for the country. In relation to your second question, we recognize the pressures on Mitchells Plain Hospital and on Khayelitsha Hospital. And your question is, when does either become a regional hospital? What does it entail? How long does it entail? So the distinction between a large metro district hospital, which Khayelitsha and Mitchells Plain is, that has specialist services. So we've already made a distinction that Khayelitsha and Mitchells Plain is not an ordinary district hospital. So you won't have the same service that you have in Caledon Hospital at Khayelitsha and Mitchells Plain Hospital. It is district hospitals because they are bigger, The emergency centers are very busy. It's district hospitals with specialist services. And actually, the distinction between a district hospital with specialist services and a regional hospital is a very small distinction. It is more on this on the availability of minor specialties like ENT, like all of the others. But the bigger specialties, such as internal medicine, there are 2 specialists at Khayelitsha, there are 2 specialists at Mitchell's Plain. As psychiatrists, there is a psychiatrist, there's a psychiatrist. If you go to surgery, there are surgeons. If you go to emergency medicine, there are emergency medicine specialists in those ECs. If you go to orthopedics, there's even orthopedic surgeons at those hospitals. But the difference between them and Somerset would be that you don't have an ENT specialist at that place. So it is the pressure points in those hospitals has the same capacity that you would necessarily get in a regional hospital elsewhere, because it's the pressure points. The recognition is that the Cape Flats, which is what Mitchell's Plain and Khayelitsha serves, is an under pressure area. The burden of disease, the social determinants that Minister is talking about, is that the pressure will be higher in those areas. So what we're doing now as part of the Klipfontein development is the Klipfontein Hospital will not be a district hospital with specialist services. Klipfontein Hospital will be a regional hospital. So then you will have Mitchell's Plain with specialist services, Khayelitsha with specialist services. You'll have Klipfontein being a regional hospital. The Tygerberg redevelopment, and I'm sure you're aware of that Tygerberg redevelopment, will then be a central hospital at the Tygerberg site, but a regional hospital in Belhar. So that's the site in Belhar, will also be a regional hospital. And at the future planning, to complete all of this in the next 8 to 10 years, is that the future planning for Helderberg, it will also be a regional hospital. So what you then have is you then have Helderberg Regional Hospital, Khayelitsha Hospital with specialist services, Mitchell's Plain with specialist services, Belhar Regional Hospital, Klipfontein Regional Hospital. That will be that entire, let's call it Cape Flats basin where the pressure is, will then be covered from that perspective. That's what all our plans are about. That is all the developments that we're putting in place. To just put that in context for you. Then in terms of the backlogs, so what Dr. Karim and his team has is, it's a very interesting phenomenon. What we have, and obviously this is now going into this financial year, but let me stick to the end of the reporting period. The reporting period, we recognized that we had a backlog on TB. So it's TB cases to be diagnosed and TB cases to be put on treatment. And we knew the backlog was manifesting in more reported cases of sick TB cases coming to the hospital to be admitted. So I can go on for each one. Diabetes, the same, HIV, the same, etc. What the team did, because what you then have to do is you need to increase access to test more cases, to find more cases, to put more cases onto treatment. So that was the strategy towards the end of the year. What the team then specifically did is then to work out in each geographic area. And Dr. Moodley over there, they started the dashboard. The marker, and it's very similar to COVID for TB. The marker is if we send a whole lot of people to be tested for TB, we looked at smear positivity. So if we test 100 cases and 17 of them are positive, we say, okay, well, there's more TB cases, and because we're testing 100, there's 17, preferably it should be below 10. So then that became a marker that where the smear positivity was the highest, that's where the biggest backlog of finding TB cases were. So that's the kind of detail that we work towards the end of March. And obviously, as we say, in the next reporting period, we'll come back with very specifics on how we did that. The other big thing that we did was for surgery, and I'll just ask Dr. Karim just very briefly to say to you, because surgery you can count. You can count how many people were supposed to have surgery in that period. And Dr. Karim will just share with you that specific number. Thank you, Chairperson. Through the Chairperson, sorry.
Through you, Chair. So by the end of March, in this reporting period, we roughly had about 80,000 surgeries that were backlogged. And that's the total combination of what we call major and minor surgeries. In the reporting period that we'll come to, you'll see some of the initiatives that we began to address it, like the robotic machines that were purchased. Minister also reflected on that. But those are obviously in the following reporting period. But the number roughly was about 80,000, which included around half of that was major surgeries that we count as more than 30 minutes, and half of that was minor surgeries that we count as under 30 minutes. Minor surgeries being like cataracts removal, like Dr. Kluti referred to in terms of ophthalmology. So those were the numbers, Chair. Thanks.
Thank you very much. Member Van Vogel, are you covered? Any follow-ups?
Yeah, Chairperson, on the healthcare workers. So, because we are not sure how long will it take, the process that was explained now. In the meanwhile, is there nothing that the department can do for these health workers? Because remember, that's the workers who don't have transport. They were working during sunny days, raining days. You will see them in the street dropping off medication and all those things. Is there nothing in the meanwhile that the department can do? That's why I'm asking, because we are giving funding to these NGOs. Because my understanding is they are receiving, I'm not sure if their minimum wage of the wage that they are receiving at the moment is 3,500. What other benefits is there for these poor workers?
Thank you, Member. HOD.
So as Minister referred to, we have no option but to stick to whatever the wage agreement is at the chamber. So there's a whole long story about what that minimum wage is. And I think it's gone up to 4,000. Is it? I don't want to speak under correction. The new agreement, it's gone over 4,000. So we'll give you the exact amount. But that is what's nationally been decided as the remuneration for community health workers. So we recognize and make sure that every community health worker in this province gets paid in terms of what's required. In addition to that, we have in the contract with the NPO additional allowances. So it's in the additional allowances that, again, we work within our, let's call it, allocation for those additional allowances. When we go further into the document, you will see one of the risks, and when we come back to you for next period, the issue about the remuneration for the healthcare sector and staff payments, or let's call it compensation of employees, is a huge risk. So whatever we commit, we need to be able to say it is sustainable and we have the resource for. So we're doing, Member Van Vogel, whatever we can within our means to supplement the allowances and then make sure that there's a fair remuneration for what people are currently getting as a standard set for the country. But that's within that context that we work with that. Yeah.
Thank you, HOD. HOD, those additional benefits, is it a national norm or is it just the Western Cape?
So we can get into the details, but the additional benefits is what we recognize. It's employment benefits, and we're benchmarking it on what would it take somebody to employ somebody. You know, so it's payroll stuff, it is uniform, it is additional things, admin fee and all of those things. So it is the cost of employing that group of people. And we've also over the years worked very, very closely with our NGOs to be very clear what that additional benefits are. So it would be almost like an employment package in addition to paying somebody's salary.
Thank you very much. You wanted to add, Minister?
I just wanted to stress that, remember, whilst we mentioned those are on the road, remember there are those who have been employed as far as in the 80s, where they were never been on PESAL, where they were the ones who were actually running the HIV counseling, counseling as part of the packages that are inside. There are also those who have added skills as a rehabilitation care workers, where there's an additional training that has been offered, like by the UCT, the physio, and all of those to assisting those patients who are unable to move. So that's why we have to follow the national processes, but it's non-negotiable in regard to not giving them what has been decided at the chambers. because they're part of the bargaining council. They've got unions, different unions that are recognized nationally as well. So it's part of it. So it's a working process. But for us going forward, what we are saying that we recognize that they are part of the health system, irrespective who appoints them. And the work they do, it's what we want them to see, because even said that we have to add some aspects of the mental health at their level, just like as they were doing the mother and child, the women and family planning, and also with the vaccination. So they are recognized in as much as that they are not appointed by the government.
Thank you so much, Minister. Is there a follow-up, member? I'm not going to allow a question.
Chairperson, you can't tell me you are not going to allow a question.
Member, you indicated that you have three more questions.
It can't be that you are not going to allow me to ask questions to the department and the minister. No, Chair, I will not accept that.
Member?
I will not accept, Chair, if you are not going to allow us to ask questions on this important annual report, telling me I can't ask questions anymore because I'm not sure what is the problem. It's 9:09. Why can't we ask questions?
Are you done, member?
I'm done, yeah.
Thank you. Member Winvogel, can I please ask that we be disciplined in that manner? Hence, I am asking members, I do understand that from a response from the department, there may emanate another question. There will be a follow-up question. That's why I'm asking. Just for the sake of maintaining order and for the sake of us moving forward, that's why I'm asking. So if you tell me that I have left out a question, can I go back? Then I will do so. But I don't think we have to be robust in the sense that I do not want to allow. That's why I was asking how many questions, and you indicated 3. But for this round, I will allow your question, member.
Thank you, Chair. The reason why I was robust is because you were saying you are not going to allow me. But nevertheless, Chairperson, mine is on the organizational environment, HOD and Minister. Of the remaining 12%, how many are agency personnel, including the respective occupations, and how much did the department spend on agency personnel during the year under review? Page 9, yeah, page 9. The reason why I'm asking this important question, when we went on oversight to all these district hospitals, that was the complaints that we received from the heads of those different district hospitals, that agency personnel is a problem for them. Thank you, Chair.
Member Winvogel, HOD.
So I think let's, if I can just through the chairperson, just address the specific issue. 33,612 staff members. So that's our total staff complement, which is people that we employ. We say 80% of them are employed in permanent capacity. That means 20% is not in a permanent position. Just explain that 20%. That 20% will be in a contract position. And as we explained in previous years, the majority of those contract positions are for interns, because an intern only gets appointed in a contract position. The sum is for registrars. They only get appointed in contract positions. And then we have short contract staff that we've employed in relation to COVID. That is 3-month contract, 6-month contract, a year contract. Agency is completely outside of that. They are not part of the 33,612 people we employ.
Follow up, Member Winvogel. Covered? Your mic, please, member.
HOD, I hear you in terms of the point of under organizational environment, but I'm not sure on it, at what platform are we going to discuss the agency personnel, because it's a concern raised by your officials in the different district hospitals.
HOD.
Chairperson, through you then, as an addition outside of the 33,000, we have outside. Now that 33,000 people, if you take all of them, at any given time, somebody will be on maternity leave. Any given time, somebody is off sick leave. And any given time, people are actually on disciplinary and on long leave out of an organization. So the institutions that you would go to against that institution might be 50 staff members that's actually paid and employed against that institution. But on any given day, there might only be 40 on duty. But 52 people are actually paid against that institution. Now, what the institutions then do because of necessity, because they cannot maintain the workload for 40 people because they're supposed to have more people, they might get in 4 or 5 people on agency to make up for the people that are actually employed and paid against the institution but is not at duty on that day. That is how agency then is part of complementing for somebody that's already paid against the institution. That is the issue of saying, how do we work with the available workforce as opposed to the paid workforce in terms of that? So it's normally, and I can tell you every time I go to a facility, I always ask that question. So how many people are in full-time employed at this institution? 56. How many is on duty today of the full-time employed? 40. So 16 not here. How many agency people you have? 6. But that is over and above the 15 people that are paid that is not on duty that day. That is the logistics of working out with available workforce, and where the agency issue then is in the minds of the staff working on the staff floor is we need more staff, but there are actually 15 people paid that's not on duty on that day. I hope that put it into context for you.
Minister?
Thanks. It's difficult to indicate upfront saying that we will have 5% of our staff to be through agent, because you also have to, you move with the flow. If it's happened that in that labor ward, there are many women who have to go to theater, but also there are those who are in labor, and therefore you need theater staff, then that's when you can pick up a phone and then you can ask the agent that, can we have a midwife or something like that. Similar with so many people in the ICU, you need a ICU a nurse specialist, just to make it an example. So it might not necessarily that you'll have planned that they should be out of my staff, they were gonna be 2 from agent, but it will be about so many bookings. Similar, when you find that, like in Khayelitsha, that there are so many of, during this weekend, of the patients assessed for mental health, they will need care. Can we have an advanced mental health nurse? But it's not necessary that you'll always know about it. And then it might be that person might be probably being asked to come now and again because you need that kind of a specialization. I recall I used to work at the municipality health services, but in between I was moonlighting at a hospital only just to go, and when the labor ward is full, to go and deliver babies. But I didn't want to be permanently there, but it was about, you call me because I'm working anyway from 8 to 4, so I might be available probably to do 2 hours or 3 hours when you are need. So it's difficult to plan ahead to say this is the amount. So it's about what Dr. Chris is trying to explain. But in terms of the what we call it, Wisdom, I don't know. Wisdom, yes. There's a system it's a national system that looks in terms of the HR dispensation in terms of the facility. We don't do at the South Africa that about 1 is to 250, 1 is to whatever. We are using that kind of a framework where it talks about what is happening. Just making an example, the clinic that will feed and refer to that facility. When you do the human resource, we have to consider that this one is managing this satellite clinic or this clinic refers to whatever. Therefore, you might not necessarily put more staff in this clinic, although there might be 1 professional nurse, but because most of the patients are referred to here, then you have to consider that probably you need to beef up your staff here during that period that there are many referrals. So it's a kind of a situation where you are unable to make it as something permanent. You move things as it flows. Thanks.
Thank you very much, Minister. Members, we will now move to Part B of the report. Members, also just note that Part C that deals with governance is also part of the report that will be dealt with by SCOPA, but members are allowed to ask questions on Part C, and Part E that deals with the financial information, pages 195 to 297, is a section that will be dealt with by SCOPA this afternoon. Members, we are now with Part B, performance information, page 27 to page 121. I see Honorable Plato, Honorable Barnes.
Just,
After.
oh, sorry, Chair. May I?
Member
Thank you.
Plato.
Page 28, just two issues on top. The clinics, the discussions, talks between the city and province. Just an update regarding that one, and maybe also just a quick comment with regard to home-based care category, if that is becoming an important component of future health care within communities. Thank you.
Thank you, Member Plato. Member Barnes.
Thank you, Chair. I'm on page 28. I will take off where Member Van Vogel left off on the district hospital. The 33 district hospitals in the province provide emergency care. I'm going back to Kailicha District Hospital. The management appeared before us some time ago as a standing committee and told us that they need about 150 million to address the bed and staff shortages to make a service delivery better there. What I want to know is that why is the department not allocating this 150 million? Are there provisions that can be made to redirect or shift the underspent funds towards KDH? That's my first one. And what process needs to be allowed for KDH to become a regional hospital? That's my first one, Chair. My second question will be on page 28, Chair, under specialized hospitals. The specialized hospitals category included 6 tuberculosis, TB hospitals, 4 psychiatric hospitals, and 1 rehabilitation. Chair, the AUMP alluded the challenge of the burden of disease, where Western Cape was the highest lifetime prevalence of mental illness in South Africa, 39%, has also affected the provision of acute psychiatric units, which created a shift in priorities. Furthermore, the 2019 rapid review of the Western Cape burden of disease indicated intended injuries as the leading cause of early death in men, in which impacts on the functioning and provision of ECs. Chair, given these are challenges, how has the department factored these into its plan and budgeting, and how are they being prioritized? What is the number of beds available in our psychiatric hospitals? And can we get details of number of patients and admitted and beds that is being utilized? Lastly, Chair, on page 70, we note an overspending on mental hospitals. Can we get details of which hospital overspended and reasons thereof? Why is the department not increasing the budgets for this hospital, as we have noted that mental illness has become the order of the day? Thank you, Chair.
Thank you, Member Barnes. Member Turgo.
Thanks, Chair. And I only have got one question, but it is in twofold. On page 27, but it overlaps up until to page 36. The question itself is around service delivery environment. The department mentions there in the report itself about the issue of the decrease of 3.2% on employment from quarter 4 to quarter 4 of 2020 to quarter 4 of 2021. And it highlights the impact of that it brought some form of a regress on service delivery implications. Now, what we want to understand, therefore, is the impact of that on service delivery itself, and what are the financial also implications that impacted on that? Because we make mention of areas such as TB and as well as other chronic illnesses that were affected by this. And then on page 36, you make mention of the under restructuring realignment on the same question. It's page 36. Now, what I want to understand that comparing what you state on the plans that you have implemented since 2016, which in terms of the MEAP towards envisaging the health outcomes for the 2030. So what was the impact of this decrease towards envisaging this goal? Thanks very much.
Thank you, Member Kego. Member Van Vogel.
Thank you, Chairperson. Mine is on page 28. On the GF Juster. The department strategy plan stated that planning of the much needed new Klipfontein Regional Hospital, which is being planned as part of the greater long-term vision for the Manenberg upgrade, is ongoing, and it will require 7 hectares of land to accommodate this 550-bed facility, which is much larger than either of the existing hospital in Mitchells Plain and Khayelitsha. And due to the limited availability of land in Manenberg, the Western Cape Department has been engaging in constructive and robust discussion with the community steering committee and local education structure and how best to affect this overall upgrade. Can we get an update regarding the rebuilding of GF Uster? And what are the details of all action steps that have been taken thus far? And what are the updates of engagements with the local education structure? And what are the updates regarding the appointment of PSP for phase 1 of the replacement of Klipfontein Regional Hospital? Of the budget that was allocated for the year under review and the current financial year, how much has been spent towards the project? And what are the annual targets for rebuilding? What tasks have been completed and what are the outstanding tasks over the MTF period? Then secondly, Chairperson, the emergency medical service on page 29. What does the National Health Act say about ambulances? What is the required ambulances to population ratio and how far are we from achieving it? And what is the breakdown of the ambulances per district in the province in the number of cases attended to? Given the high number of cases attended to, isn't it there a need to increase the number of ambulances and staff? And what is the standard ratio of EMS personnel and ambulances to population, and what is the ratio in the province? Actually, yeah. Thank you, Chair.
Thank you very much, Member Van Vogel. My question is on page 43, and it deals with the output indicator that speaks to client satisfaction survey, the satisfaction rate, which is indicated at 88.7%, which also indicates an overachievement of this indicator as it states. Does this mean that more clients indicated their satisfaction with the department holistically? And then also if the department can provide some insight into how these surveys are conducted, and especially the distinction between rural and metro areas. Thank you very much. Minister, do I give over to you?
I think most questions are technical, but I think, Chair, because it's raised a second time again and it is going to be raised, probably we are not listening or hearing each other. If I could pose a question, Chair, through you, that when we talk about a hospital to be a regional hospital, like for example, Khayelitsha, what is the understanding from the perspectives in regard the benefit because probably we are answering questions where we don't have an understanding of what is it that we want to achieve. Because if it's about the number of beds, the regional hospitals that we have is the Paarl, is Worcester, is George, is New Somerset in the metro, without counting Mowbray. These are the 4 regional hospitals. If you look at the number of beds of these hospitals and then you compare with Khayelitsha, you'll see that Khayelitsha has irrelevantly, and with a hospital that only caters only for the Khayelitsha, it has got more beds. George, as a regional hospital, caters for the whole of GRD and the Central Karoo. Paarl caters for most of the Weskus and also for the area of the Paarl. Worcester does mostly the Overberg and the lower parts of the, I think, Lanesburg and all of those in that area. But the point that I'm trying to make, when we talk about the number of beds, in the metro, other district hospitals, Mitchell's Plain, Kalbrima, is more or less the same size. So that's why I want to have an understanding. When you say a regional hospital, it means what? Because Dr. Klute explained that part of the packages in the regional hospital, it's a specialization, which is a level 2. And then you go to the tertiary or central hospital, which is level 3, which is we all have 2. So already, district hospital, they are normally categorized as level 1. And what Dr. Klute explained was about a hospital like Khayelitsha, Mitchell's Plain. They are in between. You've got packages that are between 1 and 2, like 1.5. I normally say 1.5. There's no such one. I'm just making an example. So there are services that are in the regional hospital already that have been taken out there and placed there as part of the specialization, which you don't get in other district hospitals. You go to Westphalia, you go to Caledon, you go to all others district hospitals, Prince Albert and all of those. They don't have that package that the Khayelitsha and Mr. Spain have. So that's why I want to know, what is the understanding when you say it must be a regional hospital? In numbers, it has got more beds even than other regional hospitals outside the metro. So that's what we need to have an understanding about. What does it mean? What is it required? And then Dr. Klute can respond to the other parts of it so that I could be able to answer correct questions.
Yes. Actually, we're going to give you an opportunity and then we can go back to the member.
So thank you, Chairperson, and through you, we'll take it systematically. So Member Plato's question, just an update of the City of Cape Town, also as at the 31st of March 2022, which is about 6-7 months ago, we had an agreement with the City of Cape Town based on what a council decision was in January 2022. That 9 facilities, which is under the City of Cape Town management, but happens to be under the same roof with the province, Western Cape government, would by the 1st of July be managed by Western Cape government. So in this financial year, July, that has been actioned. It was the decision in council of January was for 9 facilities that is in the same building. There was also a council decision at that time about 9 facilities in close proximity, but that was a city issue. It wasn't a Western Cape government issue. We engaged our city colleagues and said to them, that issue about the 9 close facilities in close proximity is completely a city issue, and since then the city has not proceeded to consolidate those in 9 close proximity. What has happened, before the end of March, there was also an agreement that we will look at a 10th facility, and that would be the Santa Kraal. And that for Santa Kraal facility by the end of March was also an agreement that by July, that facility becomes part of the Western Cape government responsibility. So the current status with the City of Cape Town, which is in this financial year, is for us to move towards a understanding that that is one phase in the consolidation of primary healthcare services under the authority of Western Cape Government. The process needs to be concluded during this year to get a final understanding of what exactly that looks like. So I'm just giving you that at the end of March, there was an agreement that 9+1 will be under our authority. In this financial year, that has been realized. There is then a process that once we conclude that phase, there's supposed to be a second phase. That second phase is party to what we're busy with at the moment, and it will be part of this reporting period. I hope that's sufficient. In terms of your community health worker question, sir, I think we did answer it previously with Member Windvogel's question, but let me just reiterate. Community health workers with that footprint of 7 million contacts it's an integral part of our primary healthcare system. And our commitment is to make sure that we do whatever we need to do to stabilize that platform, to recognize community health workers, and to continue working with them being an integral part of what we do. But it's quite essential in terms of what we do. So if I go to Member Barnes's question then, Member Barnes, the engagement with the CEO of Khayelitsha Hospital is an engagement to ask somebody that's sitting in one institution with all the pressures that comes into that institution. And it's understandable that that CEO will say, well, if I had a magic wand and I could get all the money that I could get in the world, 150 million would actually solve all the problems in Khayelitsha Hospital. That's completely understandable. The issue is that if you ask the CEO of every hospital in this province and get them to come to you, everyone will say the same thing. So you get the CEO of Westphalia, Westphalia will tell you we need 50 million to take all the problems away. If you go to Ceres Hospital in Witzenberg, they will tell you we need 70 million to make it go away. If you go to Caledon Hospital, they will tell you the same. You add it all up, you'll get to 5 billion. We don't have that money. So the issue is, once we have a CEO saying that's our need, that CEO needs to go back and realize I am part of a system. And that is what happened subsequently. That CEO wasn't muzzled or threatened. The CEO was part of a system to realize, actually, you ask your immediate next question is, what does every psychiatric hospital need? Now, psychiatric hospital will tell you we all need 100 million each. That is the reality of a healthcare system that we find ourselves in. If you go to every primary care facility, they will do the same. If you go to every geographic area in the province, everybody would say there is less need, less provision to the need that we currently have in that situation. That is our reality. Our reality is to say, what do we do with all of those as competing needs in a healthcare system? And again, it's not unique to us. It's an international phenomenon where people have to make these choices. Some of the best healthcare systems in the world is continually cutting service provision in terms of that. Now, the right ethical thing to do is to have a conversation in the public about what it means to have rationing of healthcare service provision. That's the right, that's the international phenomenon. It is, you will have a situation where the healthcare need exceeds what you can provide. How does everybody agree what's the best way to address? Now, Member Windvogel, when you asked one of the lessons in COVID and being ready, one of the things is we never had that hard conversation about what do we do with the limited resources we have and fairly make sure that we can't give here, but we should give there. We can't give there, but we should give here. And all of this is within the context of you knowing that we're telling you that we have a healthcare resource in this province that we are wisely using and we get a clean audit. How do we bring all of that together? So I'm giving you the honest, everything that I can. That's the only thing I can respond to your question about Khayelitsha. As the Minister has indicated, making Khayelitsha a regional hospital will not change the essential conditions on the ground for the reality of Khayelitsha. What my comment at the time was, is let's recognize the pressures that exist at Khayelitsha and competing pressures at other places, and we use our budget instrument at the end of the year to say where the pressures is higher than others, we will then adjust our expenditure patterns. So Khayelitsha is allowed to overspend, where somebody else is allowed to underspend. What our finance team is doing now is saying, what is a fair allocation of resources? If we say that there's not enough money for everyone, what would then be a fair allocation? To adjust for this, allow for this, adjust for that, and this is what is called an equity-based resource allocation process. Again, it is something that we will do as part of this financial year. So next year, we can actually answer that question to you, Member Barnes, but that is the context of the 150 million shortfall at Khayelitsha. If I go to the specialized hospital, which is your next question, again, that quote that you quoted two things there, that the burden of disease in this province, irrespective of what we do as a healthcare system, and remember the burden of disease is a societal burden of disease. And the burden of disease is not caused by the healthcare system. The burden of disease is caused by societal and social factors. Saying that mental health is higher in this province, the burden of mental health is higher in the province than in other provinces. And secondly, the burden in this province in terms of interpersonal violence affecting young men, which basically means young men get stabbed and they get killed. And if they don't get stabbed and killed, they get injured and they land up in our ECs, again in Khayelitsha Hospital and all the other hospitals on a Friday and a weekend. That is the burden we face. The answer does not lie with us. The answer lies with how society does things differently. So the answer doesn't help to say, let's add of the little money that we don't have already, take it away from somewhere else and add it into psychiatric hospitals. Because that's not going to solve the problem of why the burden of mental health is higher. What is going to solve the problem is if we engage communities, we engage people, we help them, we support young people in schools and do all of those. If we're going to do interpersonal violence, and I'm glad Mr. Lindos is here, the answer is not for the healthcare system to have more ambulances and more emergency beds. The answer is, let's prevent the young people from stabbing one another and being at the risk of being stabbed. That's why we need a multi-sectoral intervention with all the sectors, with law enforcement, with everyone else, to work in the thing called an area-based team where we can bring sectors together, to work effectively to bring those things together. So, Member Barnes, that is where the context of your question takes us to in terms of the burden, because I'm glad you quote that report, because that report says the social determinants. That does bring me to Member Klego's question, because that is then, Member Klego, exactly what you're asking us. A decrease in 3.2% employment rate amongst people. How does that impact on healthcare services? And you rightfully say to us, spell it out to us. And it's very similar to what I'm saying to Member Bond. So if you're already starting with young people not having a job, young people not having an outlet, and there's few of them, that 3.2% unemployment drop is disproportionately higher for the age group 18 to 25. So it's not even 3.4 in that group, it's higher in that group. So there's a group of young people that has no jobs, has no prospects, has nothing to live for. What's the impact is substance abuse goes up, more mental health clients in the emergency centers at Khayelitsha Hospital, at Mitchells Plain Hospital, and they can't get into Lenteghe Hospital. That's the impact of that. The impact is more young people are at the risk of being stabbed, more young people are at the risk of gunshot wounds, more of them come to the emergency centers to exactly the same hospitals. So the pattern repeats itself in the same places in terms of that. But more scary for us, because that is kind of immediately in your face, right? The scary part of that unemployment is that the vulnerable people in those households are now starting to suffer. And we're starting to see things that we haven't seen for 15 years. We're seeing malnourished children. I don't know if you've seen a report in the Eastern Cape recently of the malnourished children. It is a really shocking report. But we are seeing malnourished children in the Western Cape. It's children because there's not enough food in the house. The children are thinner, they are more malnourished, they come to the health facility sicker. So what we used to have is, well, babies coming in for the injections. Now we're seeing a lot of ill babies coming in, landing in hospital. So it is a serious situation that this 3.4% drop in employment, that's what it means, because it drives the social determinants even higher in terms of that. So if I then go to the next question, which is then Member Windvogel's question. If I can then ask that the specifics, Member Windvogel, I will give the generals about the Klipfontein, but the specifics, Dr. Angeleti de Tooy will address the specifics of what you're asking. But just the general thing is Klipfontein Regional Hospital. Again, in the reporting period, we did not expend all the money that was allocated to Klipfontein because there was a delay in the appointment of the consultants, and Dr. Angeleti de Tooy will explain that. So up until the 31st of March, 2022, we didn't spend all the money allocated against Klipfontein because there was a delay on the appointment of the consultants. Obviously, since the 1st of April, there's a different process, and she will explain because you asked about both of those. Then, Member Philander, generally, the client satisfaction survey is about a survey that we conduct once a year, but I'm going to ask Dr. Moodley to explain to you how the survey is conducted and what that result signifies, the 88.7 versus the target of 85.4. And then the last question, sorry, Member Van Vogel, you had two questions. Sorry, your ambulance question. So the last question that I have on my list is that Dr. Karim will then just give us an indication. The National Health Act does not prescribe what the ambulance to population ratio should be. The National Health Act, which is based on the Constitution, says that nobody should be denied emergency access. So it is our imperative to make sure that we have it. But Dr. Karim will give you an indication of what our current status is of ambulances per population and then staff per ambulance per population. And he will explain the difficulty that we're in, but what we're trying to do in terms of addressing the EMS question. So, Chairperson, if I can hand over, firstly to Dr. Angeleti de Tooy, then to Dr. Moodley, and then to Dr. Karim. Thank you.
Thank you very much, and thank you for the question on the Klipfontein. So the site was selected before COVID, so in 2018, and in collaboration, as is mentioned in the report, with the rest of the provincial governments. Actually, we were working in a committee that was chaired by the Premier in relation with all the other departments to try to find the site, because as you are aware of, it's quite complicated, difficult to find a site for a regional hospital. The site that where GF Uster was too small for the size of the new hospital because it was 180 beds, and now we are talking about something like 600 beds. So we were looking for a larger site. So at the end of all the consultation, especially with the education department, we agree to have actually the site that is right in front of the old site where the Silverstream Secondary School is. The education department, what is doing now is building a school of skills just on the site of GF Uster that is currently under construction. And in 2024, as far as I remember correctly, is planned to relocate the Silverstream School to the School of Skills. That I'm not sure the new name, if they keep the same name. That will be the phase one of the hospital. The consultants has been appointed just now, or in this week, and we are hoping that we can get the planning design moving. National Department has approved the project, the ISA, the Infrastructure South Africa, has approved the project, and we have the funding for the full construction as well for the medical equipment. So we haven't spent any cent so far for the reason that I explained, the consultancy as well as the site that is not available. But as soon as the site will be available, we will have to spend some money for securing the site. Probably we will do like we did for Kalicha, the fence and the bulk infrastructure. I think that I answered to all the questions. Thank you.
Thank you, Honourable Member, for the question on the client satisfaction survey. So just as a background, a client satisfaction survey is as the name suggests, it's a survey that we do every year in our health facilities. It's a paper-based survey, and different facilities have different ways of conducting it. But we engage with clients that are in our facility and we ask them a range of questions. And these questions range from access to care, experience of care, and quality of care. So a full range of questions. The important thing about the client satisfaction survey in terms of the year in question is, number one, that we are over target, and we're quite pleased about that. But we take it in the context that we're constantly trying to strive to get the best possible results, and I'll talk about that in a second. The second thing is to understand the context. And this year in question is the perfect storm year. You're dealing with COVID-19, because COVID-19 is still present, and it in fact was very much present in the year in question. You're dealing with a vaccination program, the largest vaccination program in our history, and then you're trying to catch up with services. So you're trying to get people to come back in care. So our services were particularly under pressure, and so we're very pleased that the number actually exceeded target. The third thing is that as much as the number exceeded target overall, the individual facilities need to take that report and use it as, one, an opportunity to engage with clients. This is our opportunity to talk to the client and have a meaningful conversation about what is working and what isn't working. And when we get the issue of what isn't working in a particular facility, then that it is that facility manager's responsibility to work on a quality improvement plan to improve what's happening. So it's a really good opportunity, as much as possible, to get objective information about how the clients experience our services, and then it's incumbent on us to go and improve the things that don't seem to be working quite that as well as our clients would like. Thank you.
Just on the EMS, Honourable Chair. So, I mean, Dr. Kluge said there's no national prescribed norm. There are international norms on the EMS number of vehicles per population, and WHO prescribes it or suggests at least one ambulance per 100,000 people. And that can vary between, if it's a sort of a flattish surface, it does depend on terrain, but it can vary between 1 and 100,000 people to 1 per 70,000 people. So it's kind of an international norm, and they say that should be at least. We have around 253 ambulances that are on our roads, and we can always provide a breakdown to the member van Vogel about that breakdown per district. And we do it in the Cape Metro, and then obviously for the rural areas. Just also interest, we have about 49 EMS stations around the province, and we had previously looked at some of the numbers up north. I mean, for Gauteng's population, for example, they have about 300 vehicles on the road, so they put probably even less vehicles per population than we have in the Western Cape. That being said, we also have a very large contingent of private ambulances that are added to our 253 vehicles, and we utilize those private sector ambulances very, very effectively during COVID. We in fact contracted them to continue providing services to people, and that supplemented our 253 vehicles. And it's worked so well that in the following period under review, we've in fact extended that arrangement, and that will now become a permanent feature. So we'll have our 253 vehicles, plus we'll have obviously the ability to contract the private vehicles to provide services to our public patients as well. I think there was a question on the beds, psychiatric. There were 2,337 psychiatric beds. I think there was a question somewhere along that.
Thank you very much. Members, are you covered? Are there any follow-up? Minister, you want to go? Sure.
Can I just add on the EMS? Remember, it's talking about the ambulances in numbers. It's not saying in terms of what each ambulance and also the skills, because we have got the rescue team, we have got those with the advanced life-saving, and also the air ambulance, because we do have the fixed wing, the plane, and also even the helicopters, which is one is even stationed based permanently in George, especially to consider the Oudtshoorn route. And if you look in terms of the figures, which is when the committee asks us, we can provide how many patients that they've managed to take from all the way from the Matsikama, actually even to the metro. So there's a whole full footprint of the air ambulance in regard to this space. So there are many, so you mustn't only look at that, we have got 250 something. You must understand what types of what they do, and also what type of the skills, and also part of the air ambulance, and we have got the drones and the rescue team everywhere. So it's a whole package of a EMS. But lastly, Chair, I want to reiterate what I said earlier when we spoke about the lessons learned about the social determinants of health. The question now is, it shouldn't be only to ask, why are you not having enough beds, or why are we, in terms of how many beds we must add, but we must also ask the question about what makes people to be sick. Why do we end up having so many people who are sick that they end up requiring the beds? Because that's the issue we have. It's about, as we know, research does show that about 40% socio-economic and also part of the physical environment does contribute to the person becoming ill. It's not only the person's behavior or misbehavior. In Khayelitsha, the issue of the violence that is happening there, where people in the 2 a.m. means that they are closer, they know each other, that they'll be stabbing each other. When I was there, people were pouring brain out of their head where they've been chopped like animals, if it's to say something like that. So why are we not asking the question that what is happening? That it will require that, because you can put as many beds, you can have 1,000 beds. It will look like it's a mortuary because something is happening there. Let's close the tap there. So the questions now as members we need to ask is about what makes people sick? What is it that makes people to have to keep on adding more beds? Yes, health service we will render as part of that. We'll ensure that we have got the EC, we have got the skills. But let's close the tap so that we don't end up keep on mopping the floor. Beds, beds, beds. It's about socio-economic, social determinants of health. It's about what makes those children to be malnourished when they are actually producers of food, because most of them, they are from the farming communities. How can you be a farm worker and produce food and your farm export food and feed the Europe and all of those, yet you have got children who are malnourished? That's a question we must ask. It shouldn't be about, hey, health, why your children are malnourished? Hey, health, why we have got high level of teenage pregnancy? They get pregnant there under the nose of their parents, under the community. By the time they come to us, they're already pregnant. For us, we have to dial whatever we must, make sure that it's a smooth delivery, safe mother, baby and child, but someone there must close the tap. That's what now the new questions are. Health is everybody's business. Thank you, Chair.
Absolutely. Thank you very much, Minister. Members, can I ask for us to move through this section? It's quite an extensive section, and I want you to pose your questions. Is there any questions on pages 27 to 38?
I actually wanted to make a follow-up, and then I have a number of follow-ups I wanted to do, but I want to do you a favor and just reduce it to one. I have 4 here. I will reduce it and do this favor. Chair, I must say that the questions we are asking here about, especially, let me go straight to the mental illness one. We have noticed that really I don't know, should I say it's a strange thing, but it is a burden. We can't run away from it. And the response I also welcome when the department is saying we should go back to communities and engagement. That is true. But unfortunately, we are here, we are in this department now. We are filtering those questions right through. My question earlier was, what are we doing? Because the reality, when Ayanda gets sick or mentally disturbed now, she is going to go to a hospital. That's the unfortunate situation. So what are we saying of what we are having right in front of us now? How do we address it now? And I'm not disregarding saying it's a community thing, because we are taking it into other committees. We realize there is an issue about it. Hence, we are raising it on this platform. Thank you, Chair.
Thank you very much, Member Barnes. Member Van Vogel.
Yeah, I think I'm partly covered by Member Barnes, and it's true, Minister. It's health is everybody's business. It needs our community leaders, our community to get involved. But as explained by Member Barnes, the services are needed now. And we are sitting with the department here now. So we are going to pose these questions to you. And the reason why we are putting pressure in terms of converting the Khayelitsha and Mitchells Plain Hospital to a regional hospital is based on the reports and visits that we've made, people sleeping on floors and all those things. But from where I'm sitting, my understanding is if you convert it to a regional hospital, there will be more beds and not necessary. So you are the expert. You will bring me to that level where you are at the moment. So that's why we are pushing, because that was the concerns raised during our visits there. And that's why I'm putting pressure on this issue. But I see you are saying no, it's not the case. So I will really welcome the fact that if you can clear this misunderstanding of mine, because my understanding is the Jewish Hospital will be hopefully by 2030, 31, 30, then we will have a GF Jewish Hospital. And it's really a concern. Thank you, Chair. It's just a follow-up.
Thank you very much, Member Winvogel. And I think both members hinted at the fact that I think when reality really struck for this committee is when we visited the mental institutions and we could really, absorb and realize the fact of those determining factors that impact on health. And that's why we took a resolution that we will have all those departments, Minister and HOD and officials, we need to have them here because we need to start somewhere. I understand that the members say we are here now, we are reviewing a financial year, but what is it that we're going to do going forward? And us as a committee has got a role to play in bringing those departments and saying, this is health's responsibility. For goodness sake, we don't want more mental hospitals. We don't want our people institutionalized. We already see that once you are categorized as a mental patient, there's many barriers going forward as an individual, and how does that impact on you as a human being in your life forever? So that is those kind of interventions, if I can call it like that, that us as a committee really realized on those oversight visits that we need to intervene and play our part as a standing committee. But over to you, Minister and HOD.
Yeah, I think before the HOD speaks, the quick one on the mental health. If you recall, Chair, that we, although it's not for this budget year, we made additional 30 million available for this year, specifically for those kind of where we say that, irrespective that we need 500 million to respond to the burden of mental health, because it's not mental illness, it's a whole total community mental well-being. But at least we need to do something, specifically for the adolescent mental health, child and adolescent mental health, and the older person's mental health. So that's why with that money, I think they did present here, it's about adolescent, which is, we've added more beds in the Lendegier child and adolescent mental health services. And also it's about also in regard to for the older persons at Alexandra Hospital, and we are busy now, they are busy mapping out for the Klepfontein, specifically for the Guguletu and Nyanga and Witzenberg, about it for the older persons, especially post-COVID. Women, anxiety and depression, it has gone up. But the whole issue about the adolescent mental health, where adolescents generally, even if they are not ill, they will always be in between. You are neither adult, you are neither a child, and you find that when they are mentally ill, they cannot go at a certain age to the pediatric ward. They cannot either go to the adult ward because we do understand. So we have prioritized that part of it. Similar with the mental health status of our staff, as I indicated earlier, there's no health services without health workers. But the point that we're trying to make is about the shift is a public health approach, not only on the illness when you are diagnosed. Like there might be a day where you or I or others feel like I just want to go to the clinic. I feel like I'm in a deep hole. I feel like I want to kill myself. I feel like I'm not worthy and all of those. Where do I go? Because if I go to that clinic, I'll be queuing with the babies and the mummies crying and all of those. So that's why part of the package, most of our community health centers, clinics, you'll have an advanced mental health nurse, not only who does follow up for those patients who have been discharged from the mental hospital already diagnosed, but also general, so that you can go to that queue and then you have a conversation. Is part of the package. Also, for those ones who are diagnosed, like in the case of the, especially in the rural areas, we even have got the outreach psychiatry community services, actually even here in the Khayelitsha and also Mitchell's Plain. So those psychiatrists, instead of sitting at the specialized mental hospital, they go and provide support at the primary healthcare level and also to be able to see those patients. So we're doing a whole lot of spaces around that. And lastly, as part of the Western Cape government response to the mental well-being, which is, we've got committee, it's a priority, which is Dr. Kluti and his other HODs. They are chairing that mental well-being under the dignity and wellness. Looking at the various interventions, which is the one that I'm so excited about, is about the outreaches at school as part of the adolescent mental health, going to the schools as part of the whole package, because it does need a multidisciplinary aspect. Yes, indeed. We're still far, but the issue, what we're trying to highlight is about, like in the EC and the Khayelitsha, the mental health there, where they've even made a comparison, even for the past years, is about the majority, it's as a result of the substance abuse among the young ones, and then they ended up having substance disorders and mental health, yet it's not necessarily that they are mental ill. So we do need to look at that. Now, lastly, about the issue, Member Van Vogel, I think I'm excited now you got clarity. Just to simplify it, it's like when you say district hospital is primary school, and then you say regional hospital is a high school. So you are making a case that in that primary school we took teachers who can teach biology and whatever and put them here. Although primary school, we don't teach biology and computers, but because there's a need here, so we are offering those courses that are normally offered at the high school, and we have brought these teachers there. That primary school, it might be 1,000 learners. That high school might be 400 learners. So it doesn't mean now when you convert this 1,000 and make it a high school that there will be more of the space, because the space is already, in terms of it's got to be larger. As I made an example, that if you look at the Worcester, George, Paarl outside the metro, which is a regional hospital, and compare them to the size of the Khayelitsha and Mitchell's Plain, which is level 1, those ones are level 2. You'll see that actually Khayelitsha provides as much as compared to the others. So that's what we're trying to highlight, that how do we make sure in terms of bringing all those, one of those is about the one that recently I opened, the diabetic eye kind of care for those patients, where they used to go to be referred to Tygerberg Hospital, but we brought it to the Khayelitsha, and some of the, because it's not only specialists, even subspecialists as physicians that are there in Khayelitsha, that you actually will get them at the level 2 or at the level 3, so that you stop this thing of waiting, go to, and all of those. So it's part of that kind of a package. Thank you.
Judy?
Thank you very much, Chairperson. So I really appreciate the comments from Member Barnes and Member Van Vogel. Thank you for that. So really to say, what are we doing now with the pressure that's right here? So when it comes to the mental health, Minister mentioned, we have 30 million that we've in this year's budget. So again, the reporting period stopped on the 31st of March 2022. It's in this reporting period that we're adding additional money, and that will be for next year's reporting period's purposes. That 30 million is to do specific things. And that is specifically to take in mental health the 2 biggest pressure points that causes the biggest backlog into acute hospitals. So the Khayelichas and the Mitchells Plains and Karl Bremmers and all of them suffer the most because of the mental health pressure, because your psychiatric hospitals don't have enough capacity to take people out of those hospitals, which needs to be. So then you have people on waiting lists, sitting long in this very overcrowded and busy Khayelitsha, Mitchells Plain, etc. So child and adolescent health is the big pressure point. So at Lentegeur, there's additional capacity. We were there last week and we saw the progress being made so that more adolescents can be taken into that to relieve the pressure on other hospitals. And then at Alexandra to add for psychiatrists, for the older people, dementia, but it's also psychosis for older people, so that they also gets taken out of the system, because that's the two pressure points that we have in the system. But over and above that, additional resources, and this is coming back, Member Van Vogel, to your question. Because of the mental health pressures, we put additional capacity into Khayelitsha to cope with more mental health. We didn't have to make Khayelitsha a regional hospital to give it more additional capacity. It is capacity over and above what we've just said with the 30 million to cope with more mental health clients in Khayelitsha. That's irrespective whether it's regional or district. The same goes for East River Hospital, the same goes for Somerset Hospital, the same goes for Karl Bremer Hospital. I mean, that does bring us, Member Van Vogel, to your question. We appreciate the pressure that the metro hospitals are under. And because of Member Tlego's question, the pressure will be escalating disproportionately in different areas, because the social determinants are disproportionately affecting the people living in those drainage areas. So because of that pressure, we do what we need to do to equalize the pressure across the hospitals. And that's why when I talk about a equity-based resourcing, so the answer to your question is our response, which is equity-based resourcing. Where the need is greatest, do we give more resources for the area where the need is greatest? So from these efforts, you can see we're doing that. And just the last comment on the regional hospital. A regional hospital entity is a more expensive entity to run than a district hospital entity. So if we had to make Khayelitsha and Mitchells Plain regional hospitals today, we would have to reduce what we do at the places. Does that make sense to you? To run a regional hospital, it's more expensive to run a district hospital. So if you make it a regional hospital, because of what you need to add, you're going to have to take the resource that's there and make it less. Does that make sense to you? So to add ICU, to add in ENT service, to add, and you can hear the things that I'm saying, it's not the pressure that's in Khayelitsha. To add all of those things come at a cost. And for ICU, for instance, the nursing that you need, which is nursing ICU, is a nurse, ICU nurse to a patient. If you have to add all of those at Khayelitsha, Mitchells Plain today, and you basically would have to reconfigure the resources that's used there, you would be able to do fewer things in those hospitals. And it's not that cost is the overriding thing, but it's just to put all of this together, that we look at where the pressure is. And that's why we have brought specialist services to those hospitals where the pressure is the highest. That's why we've almost selectively made certain regional departments in those hospitals. So hopefully that puts all of that in context. Thank you very much.
Members, any further questions on pages 27 to 38? Member Klego and then Member Van Vogel.
Thanks. Mine is on page 37. Yeah. On page 37, there is leadership and management development interventions. And there is a number of interventions that we have done there. But I'm very much concerned about the last one, which is women in management. The reason being is that having noted, having done a number of oversight visits to a number of these health institutions, and of which predominantly they are managed by women who carry burden between home and as well as work in terms of managing institutions. So I'm concerned about the figure that is there, that what could be the rationale behind such a low figure of women in management in a department that is led by a woman.
Thank you, Member. Member Van Vogel. $34.
But it remains while in the same targets in this indicator. There's so on page 43. So I would like to request the department to take us through the IME clinic status. What are the challenges? Why is the targets missed? Secondly, can we get a breakdown of performance for the clinics in the program units? And how many are in silver, in gold, or platinum? And is there another category in low silver? And are there clinics that did not achieve silver status? If so, what are the details? And does the department keep them missing tasks on the other clinic status affects? Where do clinics need to improve to obtain their other clinic status? And secondly, on page 35, Chair, organizational environmental training. What were the reasons for the recommendations where there any officers who were facing disciplinary issues?
Thank you, Member. Minister HUD.
Thank you. We also omitted a question from your previous round. I just noticed it now, so sorry about that. So I will deal with the question from the previous round and then this question, your question now. Thank you very much, Member Klego, for the question you posed previously, which was the MEAP, which is MEEP. It's the Management Efficiency and Alignment Program. And you were asking, how did what we did with that restructuring influence the service pressures, if I understood your question from the previous round. But just to indicate to you, the Management Efficiency and Alignment Program was focused on management. It's us. And actually, we have rationalized management. And the intention was to free more resources for services. So what you're seeing in front of us and what is on the organogram at the end of Part A is that on the 1st of April 2021, we implemented a new macro structure. That macro structure has a saving of 7.4 million, and that macro structure has one DDG less, a chief director less, and 3 directors less. So the whole output of this MEEP was that we have fewer managers. And it is 7.4 million saved. So by inference, 7.4 million that's available for service delivery. So just to put that context into you. But that leads me on to your leadership and management question. So just to clarify, the details that you see here is individuals in our department going to specific leadership events. Now, the one in the last one was a course named Women in Leadership. So it doesn't mean that we are training too little women to be managers in our department. It was just a course named Women in Leadership, and 31 members were exposed to that course. The key issue that you're asking, though, is that our senior management in our department is almost predominantly women. And when you go to CEOs of hospitals, you go to district managers, you go to our senior management, we are currently sitting in our senior management alone at about 65% women. So our entire organization is actually a women-centered organization. So everything we do in our department is really about looking and becoming a women-friendly department. So our development, our training, our exposure, everything is really about preparing the women to be leaders in our organization. So just to give you that assurance. Okay. Then the ideal clinic member, Philander, sorry, sorry about that. If you carefully look at the figure on page 34, you will see that the 21-22 year, the one under review, has 200 of our clinics got the ideal status, ideal clinic status, out of 256 that participated. So that is 78%. It is definitely something that we want to improve. So we start off, I mean, you heard Dr. Moodley also saying, this is a measure for us in the year of 2 waves of COVID, in the year of dealing with vaccination. So for us, the target is definitely not 78%. Again, in the year that we're currently in, we're making a concerted effort to increase exactly what you're asking, is how many facilities are in platinum, how many is gold, how many is silver, and we're doing it per district. But the important thing is to recognize that the ideal clinic mechanism as an internal departmental, national departmental preparation for the Office of Standards Compliance. So it's an internal evaluation. So when the Office of Standards Compliance comes, which is an independent regulatory body, and they come and visit the facilities, they appreciate, so the logic and the rationale is if you have ideal clinic status, you're likely to pass the Office of Standards Compliance evaluation. So our management team, again, next week is meeting with the Office of Standards Compliance Board to actually have a conversation and engagement with them. Because ultimately we're working towards Office of Standards compliance for all our primary care facilities. Remember, the Office of Standards Compliance will have, at some point, the delegated authority to close a facility down. And they currently come, they evaluate our clinics, they say you are satisfactory, they give you a score, or they say there's certain things that you have to fix, we come back in 6 months' time to do an evaluation. Now, I receive all those reports, and I can say to you, we've not yet had a report from the Office of Standard Compliance where they've given us 6 months to fix things and they came back and it's not fixed. And the latest one I sent about maybe 2 weeks ago. So the idea is for us, ideal clinics is not the end, right? It's a means to an end, which is compliance with the Office of Standards Compliance. And we have a directorate under Mrs. Nkosi, whose job it is to make sure that we have and take this very seriously in the department. Thank you, Chairperson.
Thank you very much, HOD. A follow-up member?
Yeah, thank you, Chair. Thanks, HOD, for that response. You mentioned that it's an independent board who normally do this visit to our institutions. That's my understanding. Is that my understanding?
So remember, just to get this, the ideal clinic status is our own facilities participating and the health system sending teams to go and check the facility, whether they meet a platinum, gold, or silver status. So it's an internal assessment. And we normally in this province take a team from one district to go check the scores in another district. And they work with our national team that supports all of these teams, and then they enter their scores onto the system, which is a unified system for the country, and then you get scores. So it's like an internal audit for the health sector themselves. I'm saying the purpose of it is not just to get ideal clinic status for platinum. The purpose is if you get the silver, the platinum, and the gold, you are in a good position than when the Office of Standard Compliance comes. Now, the Office of Standards Compliance is an independent statutory body. They have their own inspectors. They come and inform me and inform people, we are pitching up, we're coming to assess this clinic, that clinic, that clinic, this hospital, this hospital, this hospital. And they are the statutory body that by law will eventually determine whether a health facility meets the standards and whether that facility should be closed or continue to operate. So they will eventually give an issue, almost like a certificate of good standing. We're working our way towards that. So sorry if I confused that. We're not just doing the ideal clinic for the sake of ideal clinic. We're doing it in preparation for when the Office of Standards Compliance comes. We are able to score well and are able to meet all the minimum requirements to be able to operate as a health facility.
Chair, I'm not done.
HOD,
I'm not done with my follow-up.
Are you done?
No, I'm not done. The reason why I'm asking, I just want to check with the HOD. So are you saying that you send out teams to all the facilities, or are you picking out certain facilities in a certain district? The reason why I'm asking, in Kobela is Robertson. I'm not sure, I think the minister visited that place. It's a small clinic. It's a mess. Actually, it's a mess. That clinic is a mess. Safety risk. In the corridors, they pack the files. They don't have storage and all those kind of things. So my question is, are your team visiting all the facilities in the different districts? Because you are saying there was never a time when you receive a report saying this facility is not complying or must close or whatever the case may be.
I
can clarify for Member Van Vogel. We're talking about two different systems. So I apologize if I introduce confusion by talking about two different systems. The first system is the ideal clinic system, the one that you talk about. All the facilities participate. All facilities get visited. All facilities, based on what the finding is of the scores, gets rated on whether they meet the ideal clinic standard, and they are then, if they meet, they are in silver, gold, and platinum. So I just want to clarify, that's the ideal clinic. All facilities, it will include Nkobela, would have been visited and would be assigned a score and all of that. I introduced a second system, which is independent from that first system. And that is the Office of Standard Compliance, that on a 3-year cycle, try to get to most, if not all, healthcare facilities in the country. So they have samples of clinics that they visit. They don't necessarily visit, but in a 3-year cycle, they intend to get to every health facility in the country. And I'm just saying that what we're doing in the ideal clinic system helps us to prepare for the Office of Standard Compliance visits, which is separate from the ideal clinic. I'm referring to the Office of Standard Compliance, that in the facilities they visit, which they find some is satisfactory or non-satisfactory. So they don't have ideal clinic status and non-ideal clinic status. They have your facility is satisfactory or non-satisfactory. In the non-satisfactory, they give you 6 months. So I've seen the reports I've got of non-satisfactory facilities being visited after 6 months. None of that I've seen remained non-satisfactory, if you understand it. So I apologize for introducing complexity into that. Thank you.
Thank you very much, HOD. Members, we will now temporarily suspend the session to take a body break. We will be back at 10 to 11 promptly, please. Thank you very much. You're welcome to have some refreshments in the members' lounge. Thank you. 39 to 56. Any questions? (39 to 56). Member Barnes, I recognize you.
Thank you, Chair. My first question is on page 41, sub-program 2.2, community health clinics. Okay. Community health clinics, rendering a nurse-driven primary health care service at the clinic level, including visiting points and mobile clinics. Chair, what is the number of clinics that do not have full-time doctors? That's what I want to know. Second to that, with regards to those clinics under the control of the department, what is being done to ensure that there are secure waiting areas for those patients that are queuing outside from early hours of the morning? Yes, Chair, I know it's not the department's responsibility for taking care of patients that are standing from 5 a.m. because the clinic can only take responsibility from 8. However, like for example in Swellendam, though they are there from normal 8 o'clock hours, they are outside, they are standing outside. What is the department doing in cases like specific Swellendam? My second question is on page 58, Program Emergency Medical Service. Purpose, all the targets for this program have been missed. What are the reasons for that? And how were the attacks on personnel dealt with? Also, what strategies were employed? How were challenges in the rural regions handled? In moving forward, how does the department intend to deal with these challenges? Then, Chair, on pages 75.
Member Barnes, we are now dealing with pages 39 to 56.
Okay, I'll park there, Chair.
Thank you very much. I do not see any further hands. Member Van Vogel.
Thank you, Chair. Mine is on page 43. Indicator on top. Did this indicator consider the high number of patients sleeping on floor? It's difficult to understand how this target was achieved with those complaints received.
Members.
Page 43.
Member Van Vogel. Can I just caution members going forward? Remember, we are reviewing an annual report. If it's not stated in the report, you're supposed to base your questions on the report itself. I just want to caution you going forward. But you can proceed for now, member.
Chairperson, I'm not understanding your concern because I'm asking questions in line with the annual report.
Yes. What I'm trying to say, member, that if one of the indicators indicate that, say, a percentage or an amount of patients have been found to, as you are saying, not been receiving the service or sleeping on the floor, I would understand that that would justify the question in terms of how many. So I'm just saying that base your questions based on the information in the report. But you can proceed with that one. They actually indicated you answer the question.
Thank you, Chair, because that's what I'm doing. Then secondly, Chair, it's also on page 57, table on top, progress on the institutional response to the COVID-19. Can we get a detailed breakdown of all service providers used, including names of directors, value of contracts received, and BBEE's level? Then lastly, Chair, it's on page 57. I just want to check the overspending on the two programs. And secondly, were there any shift in of the unspent funds, if we can be provided with more details? Thank you, Chair.
Thank you, member. Member Plato.
Chairperson, thank you. Just briefly from my side on page 56, Just a short maybe answer or contribution from the administration side. The role played by socio-economical conditions, it seems to me, picked up by health, part of health's role, but it seems to me socio-economical conditions contribute to the mental health admission, also to the infant death conditions, etc., etc. When you pick up these issues, HOD and Minister, you convey that to other departments for their interventions and that sort of thing? Thank you.
Thank you, Member Plato. If I can perhaps just go back to page, 43. We did get a response from the department in terms of the 88.7 client satisfaction survey. That's in order, and then it also indicates the 97.3% patient safety indicated the case closure rate. These two indicators show that people, as it stated in the annual report, the year for review, that people are safe, are feeling safe and happy in our facilities. Perhaps just, I think, in the previous round, the question in terms of how this information gets compiled, the benchmark standards used between rural and metro. Can perhaps just get an indication, please? Minister?
I think I've missed some questions from Member Barnes, but probably to start with the ones that you have asked, the client satisfaction survey, which was also, I think, linked to Member Van Vogel. Remember, this is done subject to correction. I think it's what I thought it is. This is done by the independent company, where they randomly go to, whether in the outpatients or in the dispensary where patients are waiting, and then they be able to fill in the form. So it's not necessary that I've been admitted and then I fill in a questionnaire and all of those. So that you even could be able to score so much when things are just done randomly. It does, because you get a question whilst you be waiting and all of those. The last one that I think I went to was in Tygerberg, where we went also to various parts of the Tygerberg randomly, different floors, dispensary and all of those, and then ask the questions. And people don't feel like it's about, they're under pressure that they are being asked by their staff member. Because if you're already in the hospital and then you ask, how do you feel? If you haven't been seen as yet, you haven't had a consultation, you'll be actually reluctant to just throw everything in case you ended up being targeted to. So you'll find that it's just randomly and stuff. Because at the time I was with young ones who were just asking questions around that part of it. Yes, Member Plato, we do, that's why the whole of the Western Cape government identified some of the priorities. I did mention that there's a dignity and wellness. At the political level, it's under Minister of Social Development, but all us are participating. The agriculture is part of there, the sports is part of there, and also us. And then at the official level, the HODs, they co-chair those steering committee, and there's every department does make an input regarding to that. So, for example, with the issue of that you raised related to the stunting and the malnutrition, already it's about when the agriculture say that, where is that area? I want to make a follow-up. And I do know that they did make a follow-up in some areas where in terms of the food garden and all of those. The other one is on the mental health. I did mention that whilst we might be looking from the mental illness perspective, we will provide the data, but other departments need to also to make a follow-up in regard to that space. Similar with the jobs, you might think that it's an economy, but the loudest people in the jobs plan of the province is actually health, where we'll say, please granulate. We don't want you to just say, we have created 46,000 jobs. Show us where are they. And we also even push in terms of using the hotspot, like use a sub-district municipality as a boundary, so that we could be able to say, after we have done these interventions, whether it's from the economy, whether it's from education, in, let's say, in soil and dam, and then we have seen, or also agriculture, we have seen the outcomes, the impact. Look at what the data that we could be able to see. Similar with the violence prevention unit that we are busy with, which is also transversal. So we make all those input, special planning, which is part also for transversal. We make a noise even in that space. So we do work closely with them, because as we always say, that at the end we are absorbing all these socio-economic issues that are happening throughout. I think the others are technical. Over to you, Ms. Lady.
Thank you very much, Chairperson and Minister. So I'll start with Member Barnes' questions. Member Barnes, our definition of a clinic, by definition, means it's a nurse-driven service. Therefore, there's not a full-time doctor. Our clinics have then either 1 day, 2 day, or 3 day a week, doctors visit the facility. So, but by definition, a clinic, a nurse-driven clinic, does not have a full-time doctor. The second thing that you ask is about the waiting areas. So I'm going to ask Dr. Angeleti de Toey just to briefly talk about the shelter for primary care facilities where people come in and they have to wait before the facility is opened. Laura, and then I'll go to the other questions. Laura?
Thank you for the question. Yes, on all our new facility, we design what we call the pre-waiting area that is outside the main waiting area. So the staff, so the patient can come, the client can come and wait outside. Unfortunately, we don't have it for in the other clinic, the old ones. So what we are planning to do is to put up a modular shelter that we can actually procure and install everywhere where is required. We already received the list from the rural and the metro facilities that are required, and then we want to do it in modular. So can be for 20, 30, 40, depending on the number of people that is required. We put some money already available in the budget, but that is the easiest way to do it. So it will be a very simple shelter outside the facility. Some cases we have a problem with the site, but we are looking at all the cases. Thanks.
Thank you very much, Laura. So then, Member Barnes, your question about EMS, rural response times, attacks, all of those. So, Dr. Karim, if you can just quickly touch on the EMS events and our processes across all the different areas. Thank you.
Yeah, so thanks. So in terms of just the tax on personnel, also we obviously have processes in place to be able to try and deal with that. We can't prevent it, but I mean, once it has happened, we've got counselling that takes place. We've got a whole range of activity that we provide to support our staff who've been attacked. And it happens frequently. And obviously, as senior managers, we also have a process in place where some of our senior managers then go to the staff members just to support the staff. You know, we recently had the deaths of 2 of our ambulance staff members, for example, who died in a crash with a truck. You know, and we asked one of our senior managers to go there to this with the staff and just to appreciate the staff members who had died. So it does happen. In terms of, and we have lots of events in terms of trying to support our staff to try and teach them about how to respond in attacks. We've also had quite a lot of engagement with the Department of Community Safety in order to provide us with support when the attacks do happen. And obviously that's part of what we call safe zones. So we've identified vehicle routes, particularly in the red zones, where vehicles can in fact drive through, and we've liaised with community organizations in order to negotiate these safe zones. So if there's a response required, a vehicle knows which route to travel in order to try and avoid attacks in the red zones. But they do still happen, and obviously it is traumatic for our staff, and we try as best as possible then to provide support to the staff who've been affected and to their families, in fact, who've been affected. We also have a number of sort of safety measures in the vehicles, and we've also been considering placing cameras and things in our vehicles, for example, just to try and provide additional safety to the staff. And we teach the staff not to carry cell phones, etc., in terms of on their personal belongings, to try and minimize attacks on the staff. Was there another question? EMS response times? Would add to that? Okay.
So, Barnes, also then just a question about what happens in the rural areas. The challenge of a rural area is that the towns are small and they're very widely spread. And if you have an ambulance or you have 2 ambulances in a town, at any given time, one ambulance might be transporting a patient to a city hospital or referral hospital. The other ambulance have to then respond to local calls. And it becomes very difficult for that single ambulance that remains behind to actually get to all the calls. So we are looking at ways of consolidating and supporting in the different geographic areas that you have a minimum presence in each of the geographic areas. And there's some very innovative rural models where people are doing what is called the EFAR program. And it's really training local community members with first aid as a first stabilization before the ambulance arrive. So there's a whole lot of projects in the different areas to pull all of that together. Member Windvogel, your question about client satisfaction, I think the Minister has gone there. What we have here, and as it was explained by Dr. Moodley, it is our staff taking a survey of the people that is in the facility. Now that would be, I would assume it would be outpatients and inpatients. So that would be outpatients and inpatients, and that is surveying the people that's there and asking them a range of questions. So you are saying it's difficult for you to understand why that would be exceeded and why we get such a high score. That's a true reflection of what people say in those areas. So I know that this is this reported incidences of people lying on the floor and getting bad service and all of those happen to be isolated incidents, and then it is not the norm, and then it seems a lot. But actually, if you look at all the numbers of people, those are actually small numbers compared to the actual number of people that receive services. In terms of the 57, page 57, the details. So this is the institutional response at the top of 57. And what we do there is we're saying that this is the COVID resources that has been allocated in each of these areas. So you see City of Cape Town, you see Program 2, you see, City of Cape Town, Mossel Bay, City of Cape Town, Drakenstein. But you also see what it is for there. So when we say additional capacitation City of Cape Town, right, that has got specific details to it. Additional capacitation, Mossel Bay Municipality has got specific details. The field hospital in City of Cape Town, which is the third line, is a contribution specifically to one field hospital. The field hospital in Drakenstein, that's specifically to a field hospital. So that's not to an external party. It is money to run the field hospital. So the City of Cape Town one, that 15 million, that is for Brackengate, my assumption is. And then the one in Drakenstein, that is for Soonstraal, because we ran a COVID facility in that field hospital in Soonstraal. And then when it says district management additional capacity, that is for Dr. Perez, the Chief Director Office. And out of this additional capacity, that money is specifically spent in terms of this. But you can see at the bottom there, it is additional goods and services and staff capacity. So it's mainly for employing contract staff. And goods and services, it is for getting additional PPE. So this is no contract with nobody outside. It's additional money used to run the COVID response. So if you go to the next question that you have, which is over expenditure, this is back to Member Barnes's question earlier. So in this table, you can see on page 57, the third line, the third column, it says that it's break even for program 2. And that's a question, the comment I asked earlier. But you will see that district hospitals overspend by 82 million. That is where the Khayelitsha over expenditure and other district hospital expenditure lies, in the 82 over. But you see, for instance, saving against HIV/AIDS of 16.5 million. You see saving against community health centers of 38 million. And you see only 1 million over expenditure against community clinics. So we said to Member Barnes, it's break even, but within the program, this is where you were looking for the over expenditure of Khayelitsha. It's against that 82 million in the specific table. I hope that makes sense, Member Van Vogel. That's what we're looking at in terms of that table. When you then look, Member Plato, I think in addition to what the Minister has said, because you see that is specifically around mental health and interpersonal violence, exactly the two conditions that Member Barnes quoted in that report. The province has made those interdepartmental priorities. So they've lifted it out of a health priority to a Western Cape government priority. And for both those two, interpersonal violence and for mental health, I serve on interdepartmental committees, and I'm the co-chair for both. In mental health, it is with education, it's with DSD and with DCAS, and also with the Department of Local Government because of municipalities. In safety, it is myself and community safety and .P, Department of the Premier. But again, that's with SAPS, and it is with other departments and municipalities as well. The idea there is the big difference that COVID has made is COVID has allowed us to take the data. And again, Ms. Nkosi and Dr. Moodley can maybe just quickly explain to you. You asked, do we communicate this to others? The data of COVID became so evident and updated every day. People could go to a dashboard. And actually the data from health became the data of the Western Cape province response to COVID. On the back of that capacity, it's something called a provincial data center. The data center is the center where we can take all of this data that comes to the health services, and that data becomes real-time available almost on dashboards, where we can tell the story for others. So for instance, in safety, Dr. Moodley creates this data that we have in our emergency centers. Now we can tell you up to yesterday, how many people came into which emergency center with a stab wound, with a blunt injury wound, how old were they, where did they come, where did they get it? And we can show that data now to the police. So we could give it to SAPS, we could give it to LEAP deployment, firstly with the city. So the data of health now becomes the data that the other sector can respond to. And similarly, we are working on creating that data for mental health so that all three departments, so now we have health data, but we actually want education to give their data, DSD to give their data, DCAS to give their data in terms of how many young people are they putting into sports and other activities that keeps them away from crime. So if we have that data, then the data becomes the one that we start using between different departments. So that's actually the mechanism. And we know, it's called the evidence-informed and a data-led strategy. It's now health data drives the response to mental health at the societal level and trauma and violence at the societal level. Then in terms of Member Philander, I'm going to ask Dr. Moodley just to touch on that question again, because you are right. If you take as you take patient satisfaction and you take patient safety incident closure rate, it is actually a high level of the things that potentially could be a problem that is being resolved. But it's important that he just explains the patient safety closure rate, patient incident closure rate, because it will just tell you what lies in there. It's what happens to people and which potentially could be an accident and how we resolve it. And to resolve 96% of that is a very high percentage, and we close it then successfully. So I'm going to ask maybe Dr. Moodley just to reflect on that, and then maybe just I know you can get carried away, 1 or 2 words on the data to help our response with other sectors. Thank you, Dr. Moodley.
Okay, let me do the patient safety incident closure rate. So, honourable members, thank you for the question. So, you asked a question, how's it divided between rural and metro? So, I'm looking at the number now. So, the exact definition is patient safety incident closed within 60 days. And for rural, it's 99%, and for metro, it's 96%. But just so that we understand what is a patient safety incident, it is by definition, what we do in healthcare is we try and identify errors or potential for errors. And so it's not really about safety and how safe you feel, but is there a chance that a patient can get incorrect medication. And so that's a typical example. And is there a chance that a patient could have fallen? It's a wide range of things. And what we do is, even if it doesn't happen, we put it down as there's a risk that this could have happened. Now, we do this all across the world with the idea that we make a note of it, and then we put in a quality improvement plan to prevent it from happening. So it's almost a proactive mechanism to try and sort it out. And how it works is, if we note an incident, we have 60 days to resolve the issue. And 60 days to resolve that specific incident, but also 60 days to come up with a plan to make sure that it doesn't happen in the future. So that's a patient safety incident, and it's very important in terms of quality improvement. It's about doing well and keeping things going well. Yeah. So that's the patient safety incident. The data, as Dr. Cloete, I think, answered it very nicely in terms of how we utilize data. But let me give you the simplest example of why utilizing data and sharing between departments is important. So if you look at only police reports on assaults, you will get a number, let's say 20, right? We'll use that arbitrary number. If you look at the health department, though, we have 60 patients that were assaulted that came to our health facilities. Now, not just in South Africa, but across the world, this is what happens. Health picks up a lot of unreported crime. And so what we do is we say, let us take the health data and share it with our partners. Now, it's a big thing. You might think, well, shouldn't we just share it routinely? But I think something that Dr. Cloete has led, this ethos of sharing information. So we take our health data, we share it with SAPS, we share it with City of Cape Town, we share it with LEAP, we share it with anyone who can use it. And that means that they have better information on how they can respond. So I'll give you a very good example. We know that 50% of trauma deaths are caused by homicides. And 50% of those homicides are caused by gunshots. So if we did something about the firearms available, we could drastically reduce the number of homicides in the country. We've done a lot of other things. I'm going to briefly say the following. On the issue of socioeconomic factors, our department looked at data and identified early that there were concerns about nutrition. And this was probably in January this year. And so we sat down with all the other departments and said, we should anticipate that there are going to be children that are going to be hungry. What do we do with it? And as Dr. Cloete says, you collaborate with the other departments like DSD, like education, to make sure that we are proactive in addressing the problems. I'll stop there and I'll stop there.
Thank you very much, Dr. Moodley. Members, we are on part B of the report, pages 57 to 80. Any questions?
Chair, maybe I just want to be clarified on the question I asked earlier about the queues and the waiting. I didn't get the response thoroughly, or maybe I just didn't get it correctly. If I heard properly, I think the response was saying that some kind of structure will be put up at all hospitals or clinics rather. Did I hear correctly that all clinics will be having a kind of a structure outside for queuing? I just wanted to get clarity on what I heard.
Actually.
So what Dr. Angeletta du Toit said, all new places that we build, for all new places, we create something called a pre-wait area. So that is, if you come to a new clinic now that's been built in the last 2 years, there's always a place that's open from 4:30, from 3 in the morning, if people want to arrive early. We encourage people to come by appointment. We encourage medicine to be delivered to people's home. People still come early to our health facilities. But all new facilities has a pre-wait area. All our old existing facilities, what we've asked our district managers to say, indicate to us of those facilities that already exist, which ones has the biggest problem of where the pre-waiting area is a challenge. Of that list, Dr. Angeletta du Toit has got a list. So it's not all the facilities, it's the ones with the biggest challenges, where there's the biggest numbers and where the biggest number of people come. And in winter, it's a problem if it rains and those. Now, not all of them potentially will be able to put something in because some of them are on the street. You literally just have the facility and it's on the street, and then it becomes, actually it's a municipal issue because somebody's standing on a pavement or a sidewalk. But what we're doing is we have a modular solution, and we have to see at which places that solution will work. It will not work at all places. Where it does not work at all places, we have to look at other options. It's working with our local municipalities to see what other kind of solutions can we get in those areas. I hope that clarifies the question.
Covered Member Barnes, thank you. Member Plato.
Yeah, my humble apologies for getting back to the socio-economic issues and that sort of thing, particularly pertaining to children and young children. Looking at page 67, strategies to overcome underperformance, but particularly the referral to there were fewer deaths under 5 years than anticipated. But you also made reference to the fact of the late presentation of very ill children. How serious is that issue? And what do you think, what can we do about it overall, as politicians, as you say, the whole of society approach and that sort of thing? Thank you.
Thank you, Member Plato. Does that conclude pages 57 to 80, members? Going once?
There's so many questions, Jay. One don't want to ask the whole book. If you're looking at this, we will sit till 5 o'clock. So we pick and choose my here and there.
Member Van Vogel? You don't have a question. Okay. Thank you.
Okay, Chair. Mine then will be on page 75. The target, last indicator. Target achieved, there is an increase in child's death. I think it's attached to Member Plato's question, but what I want to know is what caused the increase in the children's death? How big is the increase and what was the impact of worsening socio-economic circumstances? And then on 76, the first indicator, page 76, complaint resolution within 25 working days. On complaint resolution, what were the complaints about and how were they resolved, Chair? And then on page 77, my last one will be the third indicator, inpatient bed utilization rate. To what extent did mental health contribute to this bed utilization? Thank you, Chair.
Thank you, Member Barnes. Member Van Vogel.
Thank you, Chairperson. Chair, mine is on page 63, linking performance with budgets. What are the reasons for overspending on emergency transport? Then on page, I'm going to rush, on page 84.
60.
Come again?
63.
63. Linking performance with budgets. Got it, okay. Then my second question is on page 84, reason for deviation. What is the number and causes of child death and why were the targets not achieved? What are the updates regarding the cases that could not be discussed and reviewed and what was the impact of staffing challenges? Then my last question is on page, I think it's also part 95, 98, Chair. It's on the HIV, TB, malaria, and community outreach. Page 95 to 98. Okay, yeah, while the department claims to meet most of their targets, it is rather concerning for me that the number of serious targets have been missed. Can we be taken through the reasons for missing the targets as well as measures put in place to address the persistent underperformance on this program? And what are the challenges with the TB and HIV targets, especially the tracing of defaulters, and why is the department always missing these targets? How is the department planning to address these challenges? Thank you, Chair.
Thank you very much, Member. Minister Ochudi.
I think for me, it's just a general question, a response related to the child deaths and the socioeconomic conditions. If you look at the age group, the under 5, general, the under 5-year-olds, before birth, which is during the time that they are still in the mummies are pregnant, you'll be able, the health system could be able to track the health status of the child. The child gets born, mostly delivered at the health facility, you could be able to track that. And then during the immunizations, which is starting from birth until, I think the major ones, let's say until age 2 years, generally. When the child comes to the clinic, you do both the growth monitoring, you could be able to assess they've got the road to health card. But usually, once they are done with the immunizations, right about age 3, because sometimes they'll come back later, between that time, that's when actually they are not much within the eyes of the health system. So that's why you will rely on, because some of them might be in the ECDs during that period. Before they even go to school, they may be in the ECDs. So it is the time that generally, internationally, the issue of the under 5 child caring becomes quite of wobbling, because they are not at school, they are not coming to the health system frequently, but they are there at home most of the time. So that's why you'll find that the issue of the severe acute malnutrition, what we pick it up, it might be that it's quite far lesser compared to what is happening outside there, because those children, they are not necessarily much as part of the health system, because they might be left with 1 or 2 immunizations. And if there are no ECDs, which is, I like that, the emphasis that even the ECDs now are transferred to the education, it will make it sure that we don't leave any child, specifically under 5-year-old, behind, so that we could be able to have the whole package of assessing the child. Because some of these ECDs, they are not necessarily those high-level kind of professionalized ECDs that you often see in the suburbs. Because some of them might be the auntie who's just collecting all these kids and taking care of them, but not necessarily that might have the know-how in regard to that space, or even to check in terms of the immunization card. So those ones that are listed here are the ones that will end up being able to pick it up, but I bet you that there are many of those. When I was in mortuary, actually in the Salt River, in the forensic pathology services, they are doing with the other universities in the KZN specifically on the child mortality, where they were saying that, and also with the UCT child gauge, where they were saying that they've seen quite a large number of children that they are doing their postmortems to, which those children might not necessarily have died in the hospitals, just to show that there are many children that are being left behind in regard to that space. Yes, indeed, we work all of us closer together with the Department of Social Development and also with the other departments in regarding to making sure that there's a safety net for these children in regard to that part. And then lastly, the part of the pneumonia, remember a long time ago, not long time ago, pneumonia, diarrhea, they also form part of the expanded program of the immunizations. So actually, as a country, even here, the numbers of children dying needlessly from pneumonia have been saved if they are part of, they've taken some of their immunizations as part of the package. It was introduced a long time ago about it. So we don't have as many cases of the children dying from pneumonia compared then, but I think the issue for the 2021 is that time of the COVID, where there have been child neglect generally, neglect because they are no longer at the ECD, they are no longer anywhere, they are around maybe on the streets, and also because the schools or the ECD, some of them were closed. So it ended up that we're having this kind of a situation where you might see that, but 2021 is where things were not as steady in any other parts, community, other sectors, and also us. But I think there's a somewhere in the report where we say that for 2022-23 strategy to overcome underperformance, in that page 84, where we say that for 2022-2023, we have to ensure that we keep on tracking all of those, because 2021 was a different kind of a period. Over to you to talk.
Thank you, Chairperson. So I think just to add to what the Minister said, so for Member Plato's question, I think the question that we did say, Member Plato, which is the difficulty, is because this reporting period had a third and a fourth wave, what we saw, which is the beginning of beginning of 2022, so the beginning of this year. So the last 3 months, January to March, we in a sense, because the third wave was in July, it's quite high. Then the fourth wave was this big Omicron wave, but we didn't have that many hospitalizations and deaths. So December, January, February, we came out of the fourth wave. That 3 months, January to March, we then picked up this phenomenon that during all 4 waves for COVID, children were actually protected from the normal exposure of infection that they would have had in other years. So almost like the side effect, not the side effect of COVID, is the children were stayed in homes and they didn't actually mix a lot with other children. So your normal runny nose, snotty nose, you didn't actually get that. So because towards the beginning of January this year, there was a relaxation. Children were going back to creches, people were doing things, and generally people did all of that. The immunity of the children was compromised because they were not exposed to what would be normally. When we were children, people saying you go to the creche, you get a little bit of a runny nose and a flu, but your parents always to say you now have immunity, you know. So it's almost like 2 years worth of not having that. What we then found is that children then became quite acutely ill in that first 3 months of this year. And it happens to coincide with something called diarrhea season. And that's why when it comes to the diarrhea to the child deaths, the question Member Barnes asked, there's more diarrhea deaths in this year than it was expected because the diarrhea season was higher because children all of a sudden had more exposure to diarrhea and they had less protection against diarrhea. So that was almost like a rebound effect, Member Plato. So both the children were a little bit iller because they weren't exposed. But the second thing that happened during COVID is because parents were looking after sick children, they were scared of taking them to hospitals. And they came late to the hospitals. So both those two is a phenomenon of the impact on the behavior of parents in relation to their children. So both those two coincided in that January. That's why we had the big peak of diarrhea. It's almost like the diarrhea season was gone for 2 years and all of a sudden it came back with a huge bang. And it carried into this financial year. Red Cross was under severe pressure late into April, May, June because of this phenomenon of almost like a big rebound of childhood conditions. So for us, that is a phenomenon that we can explain, but there's a broader phenomenon that underlies that. The broader phenomenon is people have less food, people have less money for childcare, people have lost jobs. So the broader phenomenon that underlies that is that children are now more at risk. And they're at risk because they're not getting the childcare that they should be getting, and they're not getting the food that they should be getting. So that worries us more, the underlying phenomenon. And that's what, when you ask the question, what do we do with communities and to multi-sectoral platforms? A society should be measured on how well it looks after its children. That should be a measure. And health will tell you that the children are now at risk. And children are at the risk of illnesses and potentially for malnutrition and for dying. Therefore, we should use this data to advocate for platforms, to support families with small children, because that's where the risk is currently sitting. So just to give you that kind of context.
That's why I asked the question. That is why I made the remark, because politicians must get the message across the board, from national government to local government. There's a problem, a societal problem, we as a whole must address. You answer the question on page 74 yourself, there right in the middle. Due to the worsening socio-economic circumstances, we need to take note of that. That's for me a serious issue. Patients are presenting with more severe disease requiring a longer hospital stay. So the impact on hospitals, the impact on the medical system as a whole, and because of adverse home circumstances, exactly what you have said, the issue in the community, the issue at home. And we can't want to close our eyes for things like that. Thank you, Chairperson.
Shuri?
But actually what that is testimony to the fact that one thing our systems learn, and the members here in the room will know that, because I've had many messages from members, our responsiveness of our system has really become, people respond much quicker and much faster. And this is the reason why we have that. So it's almost like our services, everybody takes everything very seriously. They respond to the money. I'm a leader often, but when I see, maybe the also in some ways, the lady was out within 2 hours. It's a specialist with, those kind of things didn't happen in 3 years. It's just the way our system is built. That people want to help, they want to respond, and they take patient complaints serious. That to me is what I understand. Then I think the question that you asked,
Judy, sorry, can you please just put on the mic? Thank you.
The question that you ask about the inpatient data on page 77, because I can find average length of stay, I don't find inpatient mortality, but that's the ones I looked at. You asked what's the overlay of mental health. My response to you, if I understood your question correctly, on page 77, is that it's the point that member Plato also raised, is that average length of stay, the severity incident report, and the bed utilization has all been affected because people present later to hospitals. It's all linked to that, but this now might be mainly adults because children are crowded out by this data here. And it's all because the question that Member Windvogel started the day with is now all of a sudden we have sick TB patients coming, but we didn't pick them up, they didn't go for testing, now they come to a hospital. So there's a whole range of them, and mental health is one of them. So the reason all of these things are affected by the socioeconomic conditions, and it's driving both TB, HIV, diabetes, but also mental health and everything else. So for the adults, we are seeing the length of stay is slightly longer than it should be because of the late presentation and the fact that people have poor conditions and the social conditions. Hopefully I've answered your question. I think, Member Windvogel, the EMS question that you say linked to performance, the only thing I can find in there is that what Dr. Karim responded to earlier is our EMS is under pressure all the time. But at the peaks of the waves, the EMS pressure then exacerbates. And what we've done in this reporting period is to draw on private EMS during those peaks, so that our overall performance from a client perspective was actually relatively good and well maintained. It is not that under pressure EMS and now you have the big pressure of all the COVID cases, that the EMS came to a standstill. Actually, we moved with that wave of more requests. And it's because of that that we've carried it into this financial year. So what you need to read there is you need to read the performance of EMS in terms of at the highest periods of peak. And remember, in a week, high period of peak is normally on a Saturday, a Friday night to Sunday. That's most of the time that we get complaints of people saying they're waiting, the ambulance is not coming. It's just that the calls are so many and the ambulances just can't get to even. On top of that, you add COVID. That is what those peaks, and we smoothed out that experience with having the additional private ambulances being part of our system with a formal contract in that period. And now we continue to leverage off that for those peaks of demand. The child deaths, I think this is the child death review, the minister said. Now this is different from the others. This is where we have a panel of people that's appointed from various sectors, forensic pathology, so they look at the death, all the unnatural death of children. And actually they're looking at all deaths actually. So every death gets investigated as an abnormal event. So every child death. And they go through the notes, they go through where the child was, whatever, and they do a formal evaluation in a rule to see if there's any system failures that can be picked up and be reviewed. Now, obviously, as they say there on page 84, what our challenge was is that this was partially achieved because not all cases could be discussed and reviewed. And it's really because that in that time, the pressures was quite high. So you can see it was an abnormal time. So if it was a normal time, we would have done all the cases. But in that time, we couldn't get to every single case because every single case is quite a detailed investigation for all of that. Then it brings me to your last one, which is your conditional grant and target met from page 95 all the way through to 96. The basic answer to your question, all the way to 99. The basic answer to your question, if we go according to each of these targets here, so I'll take the ones where you say that there's a difference between target and performance. Male condoms. Now, we said we wanted to have 16 million male condoms distributed. We only have 72. This is purely due to COVID. The whole distribution of condoms is the male condom distribution program was based on the fact that people socialize. So we normally distributed condoms at gatherings. So people come to schools, they come to clubs, nightclubs, they go wherever. COVID took all of that away. So obviously the target was impacted upon by the fact that COVID changed how people socialize. We have to rethink what we do with condoms now as we start re-socializing and all of that. But in this period, there's a very clear explanation of why that was not met. If you look at female condoms, the same obviously applies, both male and female condoms. But then the others, you can see we overshoot, go whatever. Then the referrals of individuals for a referral service. You can obviously understand the referrals, same as we said everything else, would have dropped during COVID because picking up somebody, referring them for somebody else, that would have been one of the services that would have been displaced by COVID. And therefore, it's an expected drop in performance. Now, I can go through each one. I can say to you almost without contradiction, the ones where the performance dropped is as a direct result of COVID during that specific reporting period. Because the next one is number of clients tested. Again, people were not coming forward to be tested for HIV because everybody was testing for COVID. And the people didn't present themselves for HIV testing because you're scared to go to a health facility to go test for HIV because you're scared you're going to get COVID. So that is all the things, and it literally is every single one where we've not achieved. You can have that explanation. Thank you, Chairperson.
Thank you very much, HOD. Members, can we conclude on Part B?
Will be done. No more questions on my side, but just this last one. I'm not sure if it is a remark or what, but it linked in with the socio and the death of children. I think page 64, or actually 84. You had given all the answers so beautifully, Honourable HOD, but then you say you need proper research, and that's I think then the middle. To reduction number of deaths deemed to be due to natural causes, the detail of which will require research. What do you, by saying that, what do you mean by that? If you have all the answers, why must you on top of it still do research for?
Thank you, Member. Member Barnes, and then Member Van Vogel, and then we will conclude with Part B. Members, your follow-up questions, please do make use of your parliamentary privileges. We really want to give the members of the public also an opportunity.
Thank you, Chair. My last questions will be on page 88, the bottom table, reasons for deviation. What are the updates regarding the projects that are stated at page 88, Chair? And then my second one will be on page 90 to 93, the table, transfers to non-profit institutions. How are these NPIs selected, Chair? And please provide details of the NPOs as well as the names of the board that are serving on these NPOs, Chair. My last question, Chair, is on then page 93, the bottom table, the first two rows. What are the details of these claims, and how many were they in total, and how many were related to COVID-19, Chair? My last question is on page 101, Health Facility Revitalization Grant. The funding allocation for infrastructure was mainly provided through the Health Facility Revitalization Grant. Chair, what I want to know here is what are the reasons for the underspending and missing targets and details of facilities affected, and did the department surrender these funds or were they applied as rollovers? Okay, if I can just get clarity on that. Thank you, Chair.
Thank you, Member Barnes. Member Van Vogel.
International health facilities. How does that come with these professionals? Are they in trade possession? And then what is the breakdown of these health professionals per occupation, race and gender? And how did this...
Member, your mic, please. Member Van Vogel, your mic.
Yeah, on the NHI grant, I just want to check with the department, how does the appointment of these health professionals work? Are they paid per session? And what is the breakdown of these health professionals per occupation, race and gender? And how did this improve health services in the province? And what is the expenditure breakdown? And then lastly, on page 106, if any of the workers were recruited from agencies, can we get a breakdown of these agencies and how much was paid to each and number of staff per agency? And are there any posts that were made permanent or staff that ended up being employed permanently? It's also on the NHI grant. Thank you, Chair.
Thank you, Member Van Vogel. Minister, HOD.
So let's start. Thank you, Chairperson. If we can start with the last question from Member Van Vogel. On page 106. On 106, it's very clear there, 357 staff members, and the breakdown is clear. These were not agency, these are contract appointments. As I explained earlier, this is the number of people that in that total where we said 80% is full-time staff and others are contract. This is a sub-component of our contract staff. So no agency, everybody was appointed on contract staff of that 357. Now the question that you're asking is at the end of the reporting period, which was the end of March 2022, all of those people were still in contract. Now what happened to them subsequent in this financial year is what we will report on for next year, but they were all in employ at the end of March. So can I move on? So that is then the 104. The 106, sorry, that's 106. So 104 is then the NHI sessions. So again, these are sessions, and it was for select health profession sessions that were journalized against this for that amount. And this is specifically, if I get the geographic areas correctly, specifically for Garden Route. Specifically Garden Route. So this is Garden Route, and this is for mainly for medical doctors, and then for other categories of staff. So there would be some clinical nurse practitioners, there's dentists and dental assistants, but it's mainly medical doctors and mainly dentists and dental assistants. So those were the ones that were specifically targeted by the grant. And you will see there's a note further on, not all the sessions could be filled because there were not enough people that could be appointed on sessions. And specifically around the dentists and dental assistants, there were not enough people, even in private sector in Garden Route, to put them all on sessions. There were obviously enough doctors to put on sessions, but not those other two. So that is the geographic area, that's the breakdown. And what they do as sessional doctors and sessional dentists and sessional dental assistants, they work in the primary care system where they are needed. So they would go and do their sessions as part of all the clinics in that geographic area. If we then go to page 1, I'm getting myself, not sure what that is 101. Work my way back. 101, I think is Member Barnes's question. The health facility revitalization grant. And there's also on page 88 a list of projects. So I'm going to ask Dr. Angeleti du Toit to answer those two questions. So the 106 question and the 88 question. Laura?
Thank you. The question was, thank you for the question about the reasoning for the underexpenditure and if we ask for rollover. The second one, yes, we asked for rollover and we got the approval from the Department of Health and Treasury. And the reasoning for under expenditure are quite a few of them. I don't want to say again, but COVID had a big impact on the industry. Also, not only for the construction, but also for the medical equipment. Remember, with this grant, we buy medical equipment also. And the fact that it must come from overseas and the logistic crisis that came up after COVID and lockdown of the Chinese harbor in Shanghai, where some of our equipment are coming from, actually had the effect that we couldn't receive the equipment and install it on time. So we asked for that and we got the rollover. On page 88, sorry, I just want to, yeah, the observatory, yeah, we finalized some of the project, but some of them we had some delays, like the Sandy Point and the issue of the Cape Medical Depot. As I said, there are these projects are implemented, some of them by us, some of them by Transport Public Works, that are also experiencing some delays with the COVID pandemic. And then we achieved at least the DUARS and ambulance and the observatory forensic pathology. Yeah, thanks.
And then there's a question on page 93 about claimants. It's payment to households. I'm going to ask Mr. K to explain payments to households. Mr. K, are you the right person to explain what we mean by payment to households?
Thank you, HOD. I think the question is more around whether there were any COVID claims. That's within the payment to households. Am I just seeking clarity?
So the question was, okay, sorry. You go ahead, Member.
And proceed, Member Barnes. Okay, the question was, what are the details of these claims? Yes, how many were they in total and how many were related to COVID-19?
Okay, so the detail and the classification is provided. I think the concern is around the claims to the state. So that is the medico-legal. That is where those claims are paid from. There were no claims in this province relating to COVID because the COVID claims were covered at a national department level. And the details for the medico-legal and the cases are in the annexures to the annual financial statements. And I will find them and I will direct them. If we can just go to the next question, I'll find the page reference and I'll direct to the details.
So Member Barnes, the first payment there, which is called injury on duty, leave gratuity, retirement benefit and severance package, that is paid to our own staff members. And that is 77 million. So, and it is really what it is. It's a payment because somebody sustained injury to duty, it went through the compensation and we pay it out to the person. Somebody that's retirement, so that's retirement packages and benefits that gets paid to somebody. And if somebody have a severance package, somebody has applied for VSP, that's the payment. So that's the 77 million, that's the majority of the money that's paid there. The next line, which is claims against the state's households, is what Mr. K is talking about. That 64 million is what we pay out for medical legal claims. And as is just indicated, none of that is for COVID, because any claim against the state from a medical legal person from COVID or vaccination was dealt with the National Department. These are for other conditions, and in the annexures, there's a detail of what exactly each claim was paid out for. Then there's bursaries. Obviously, bursaries is quite straightforward. It's for students that are studying, and that's the amount that goes against that. And then payment made as an act of grace, I'm not sure what that is, but 48,000 rand, not sure what it is, but obviously that was done as a compassionate act to somebody in terms of, yeah?
That was contributions to some of the funeral
The
costs.
funeral cost.
For some
For staff members.
Some people that passed, sorry, through the chair.
Yeah.
It was particularly the one of the nurses who passed at Tygerberg, and the repatriation of the body and the inability of the family to be able to afford. We made a contribution towards that. Yeah.
Mike, please, HOD.
That's a breakdown of the claimants. And then if we can then go to a very good question, Member Plateau, if we have all the answers, why do we need the research? But I think what this says here, there was a major reduction in the admission of sudden unexpected deaths in children to forensic pathology. And it's basically attributed to a reduction in number of deaths deemed to be due to natural causes. So what it is there's a sudden drop in one category. And it's because of a classification that all of a sudden how we view natural causes, it is changed. So the category for natural causes was narrowed so that you have more investigation for unnatural causes, if you understand. So they think that the sudden drop of unexpected deaths is due to that classification of the data. And what they say, it requires research. We just need to go back to the individual cases and to go see whether that drop really is due to the change in classification. So it's technical terms just to explain that specific one. Thank you. If I got it right. Yeah. Thank you, Chairperson.
Thank you very much, HOD. You covered. Thank you. Members, we're going to move now to Part C. Governance, pages 125 to 140. This part will also be dealt with in SCOPA. With the members' indulgence, can we then move over to Part D, Human Resource Management, pages 143 to 193. Members, can I also ask that can we limit you to one question? One and a half.
Pose at least two, Chairperson.
1.5. If we can do that very swiftly and to the point, Member Van Vogel, so that we just have time for the members of the public as well. You may go ahead, Member. Thank you. From page 143 to 193.
Thank you, Chair. Mine is on page 149. Sorry, 147. And then also 149. I just want to check with the department what are the details of this plan, as well as the update on the new EEE plan that was in the process of being developed. Then on 149, were there any support offered to, oh, but you did cover that one. Yeah, so I'm not going to ask that because the HOD explained. So there was support given to healthcare workers. Then the last one, Chair, then because you agreed to 2 questions, can we get on page 149, can we get the exact figures of the 29.47%? Thank you, Chair.
Thank you very much, Member Van Vogel. I do not see any further hands from members. HOD.
Thank you very much, Chairperson. So I would ask Mrs. Aris to give you details of the employment equity plan, because it was quite a detailed process we went through, and it's also a provincial process. So we will explain to you exactly what the process is, but we are pretty proud of our progressive approach, I think, to the employment equity, and we're doing it broader than what the Act asks us to do. So we'll explain the details. Then in terms of your overall total engagement, all the services provided amounted to 29.47 during this period under review. It just indicates to you that a third of our health workforce, if I understand that correctly, 30% uses the service. It just shows you how important it is to provide employee support. That 1 in 3 people use this is a very, very high. I mean, the normal benchmark update is probably about 12%. So if you think this is almost 3 times, or at least 2.5 times more than what will happen normally. So it's doubled 2.5 times. People have actually started using our services. And the detail is provided actually in a momentum report. There is a metropolitan report that gives us specific detail of what exactly people have come through and what kind of support they sought in terms of this. But just to say that we commend our well-being team for the uptake, the availability, the visibility. That's why we actually have 30% of people taking up the service. But over to Mrs. Aris about the employment equity plans.
Thank you. Thank you for the question. So firstly, this is from 2017 to 22. This is the plan that we have listed here. It's the 5-year plan of the past 5 years. And included in there is both the targets, the norms that are set in terms of race and gender, as well as the issue of how we deal with policies, what needs to be informed, the barriers that prevent us from employing people, and specifically the area, and we are very, well, we are proud knowing, yet understanding and knowing that we're not completely there, the area of disability. So it's not just the numbers that we are talking within that, but importantly, the assistance that we provide, how we recruit the individuals, how we support the person through the entire process. So it's a very encompassing process. We have a forum that's both organized labor, that's part of that. And we have been reporting to Department of Labor on a regular basis. And now we have, as Dr. Cloutier have said, we have just drafted and have completed the drafting of our new plan that started the 1st of September 2022. And in that, we are, again, the issue is not just about numbers. The issue is about how do we transform, how do we change the culture in our organization for people to be comfortable to come into it, both in terms of access, keeping people there, recruiting them appropriately, but also how do we deal with succession planning, the area of how we support people through processes. So it's quite encompassing, and so it's for us it's important that we in this plan we are looking at how to address the barriers to get to all the targets. And as Dr. Klutia said, in terms of wellness, we are really very happy where we are. But importantly, in terms of the uptake, is because people are comfortable to do so. There are confidentiality in this process, and we have made sure that we spread across the organization. And so therefore, we also in this particular time of COVID and the healing sessions that we've mentioned specifically, the intention that we have was very clearly brought about in this space. Thanks.
Thank you very much, Mrs. Aris. Member Barnes.
Thank you, Chair. The last speaker just intrigued me on what I've read on page 60, recruitment of certain health professionals. The recruitment of the qualified and competent health professionals possesses a challenge due to the scarcity of specialties in rural areas and the restrictive appointment measures that are imposed on certain occupations. I heard that the speaker was just saying speaking of a plan. What I wanted to know if the department can provide details regarding this challenge as well as strategies that are put in place to address it. If there's the plan, can the plan be shared with us? Then my last question, Chair, is on page 159, the second last paragraph. During the 2022 cycle that commenced on 1st January 2022, a total of 842 medical interns were placed at our 11 health facilities. Chair, what I want to know, in the past few years, there was a challenge regarding unplaced medical interns as well as complaints of some interns experiencing burnout due to being overworked. How were these challenges addressed and whether the department experienced any challenges in this regard? Thank you, Chair.
Thank you, Member Barnes. Actually,
Chairperson, I must apologize. I didn't get Member Barnes' first question, but if I can try and just play it back to Member Barnes if I've got it correctly. It was the challenge of attracting certain professional categories to work in rural areas, and what are we doing to overcome it? Okay. So, part of a professional health service is, again, a global phenomenon of how do you get certain professional categories to work in underserved, very, very rural areas, because a professional category person normally have career aspirations, family aspirations, and actually are looking for job opportunities for their children, school opportunities for children, job opportunities for a partner is a very important consideration. And basically just the social conditions where you actually grow up and raise your family. So against that backdrop, it's very difficult to compete for a young, newly married couple with small school-going children to attract them to a rural area where those aspirations cannot be fulfilled. So what we do have, which is on the back of the community service program, is because we place and we've prioritized young professionals in community service for rural towns. We have a preference and we prioritize. So we have a category 1, priority 1, 2, 3. So if we can, we place all community service doctors in small rural towns. So normally that would be community service doctors that are obliged to do the work. They generally maybe not all married yet, and they're young in their careers. And through that placement of young doctors in those placements, they just fall in love with the town. It's something, if they would have given the opportunity, their first choice, they would have wanted to go to a city or somewhere. A lot of doctors actually just fall in love. And the Beaufort West example is based on that, is that there's a lot of young doctors then. And what happens with young professionals, word of mouth becomes a very powerful thing. So if somebody had a good experience and then knows somebody else, they will encourage them, come here, it was a good experience. So actually, we're now sitting in a situation where every year we are being asked for community service placements in other provinces, want to come to the Western Cape and to rural towns in the Western Cape because of the experience that people have had and through that. So it's a very, that's what we do. And then, Member Barnes, in Beaufort West, so you know the people I'm talking about. So you have to think of Dr. Bram Miller. He himself was a student that worked there. He was also placed in the community service he became the manager, and he is attracting other young people to come into that area. So that's the way we actually do it. It's very difficult to do it in any other way. It's a word of mouth. It is what people become comfortable with. And there's also something about somebody qualifying and going to somewhere and wanting to work in the area where they grew up. So it's also targeting that we want to actually bring people back that comes from a geographic area that has some social network and an ecosystem that they can fit into. And by extension, because we do that with doctors, it then by extension becomes easier to do it with pharmacists, to do it with young dentists, to do it with young OTs and physios, because by extension we can do that. And then also with nursing, with community service nursing, we do a similar event. So I think we are pretty successful in the attraction. There are some places that we just cannot attract anybody, and that's very difficult. There are small towns. It's very difficult to hold somebody and to keep them there. And you also know those towns. Maritzburg is one of them. It's extremely difficult to keep people there and to do that. And then your best bet is then at the nearest, closest town where you can get people, add more people so that you can get one going out there. And so those are the mechanisms that we use to do that specific one. Just to talk about interns then, because it's linked to your question of interns. So the issue of the 22 cycle is that there was additional resources made available from the national department because of a huge under availability of posts countrywide. And what happened is the National Department then made additional resources available, and we in the Western Cape then took in additional interns. So the intern problem that you described, which was very evident between Christmas and New Year of 2020, so 2020, yeah, and it ran into 2021. Was obviated by the fact that additional resources came into the system. So we, as other provinces, absorbed our fair share of additional people into intern posts, but also community service posts. To the fact now that actually the allocation of interns in Cosmos actually happened last week, which is for the first time in many years. It's now happening, before we enter November. So now it's almost like a two-month head start normally, and there's just generally a feeling of people are feeling a little bit more secure now this time in terms of the placements of intern. But for us, the intern question is a bigger question. Again, there's a national process, and I'm also serving on that committee with other HODs in the national department about whether we should be looking at the community service program and the intern program and do a formal evaluation of its effectiveness and what should be happening. But the short answer is we have interns placed. They are in what we call complexes. So you will have interns placed at Worcester Hospital, but they will also do service at smaller hospitals from Worcester and communities. So we'll have interns placed at Victoria Hospital, and they will have placements at community health centers around them. So our system is actually quite a sophisticated system of absorbing the interns into the healthcare system at the hospital, but also the surrounding community health centers, where they then have to do overtime, but also the day work. And that's how Atlantis and Westphalia also has 2 or 3 interns. Although they supposed to be with Somerset, they actually physically work in Westphalia. Where people are supposed to be at Easter River, they work at Kleinvlei. That's how we actually absorb them across the system. Thank you.
Thank you very much, HOD. Member Teugel, is that a closing remark?
Yeah, maybe it's depending on the response of the department. Mine is on page 172 on an issue of the disabled. Why we do not have anyone with a disability on the top management and senior management of the department? Is it maybe the department doesn't prioritize them, or what could be happening? And then the second one would be on page 178 in terms of the profession of lower skilled employees by salary band, why there hasn't been any progression. Looking at the fact that we were coming from COVID, and then where everything else in terms of budget was mostly allocated to rendering of services, and then staff progression was being canned by government deliberately, so understanding the issue of adjusting funds to assist with the impact of COVID. But now we note that we're having noted all those reasons that or conditions and that you find yourselves in, but at a broader level, that these are the people that feel so much financially distressed and as well as depressed emotionally and with workload. Thanks very much.
Thank you, Member. Actually.
Thank you very much, Member Teko. On your first question about disability, I think it's a very interesting question because about 2 years ago, our colleagues in people management did a survey. And there is this question about whether somebody with a disability declares that they have a disability. So not everybody that has a disability declares that they have a disability. So I would like Mrs. Aris to comment on that. And especially in more senior categories, people are not willing to declare their disability. So the second question about NOTS, I've also asked Mrs. Aris, was just a blanket rule that there were no NOTS progressions, and it's a technical issue. But Mrs. Aris will explain exactly why we took that decision. But on both, Mrs. Aris, thank you.
So it is, if you look at it, it does stand out. But as Dr. Cloutier has, and then you must also realize that there's stability in the top management. As we've recently appointed and made shifts. So, but at the same time, very importantly, we've gone, and it is a constant question that we ask people to declare, because it is important that we give that, but it's also confidential, and people would not like to do that. But at the same time, it is, as a department, when we advertise our post, we indicate very clearly that people must indicate so, and clearly in other spaces we get that right, but in some areas we've not done that. So the issue on the no notch progression has taken place in this financial year. So that's the answer to the 178. It is still something that must be completed. So that's what will happen. It will be reflective in this new financial year, because there's this issue of salary negotiations, and then we will implement. But we've done all our assessments, and things have been completed. It's just a matter of when the negotiations are completed and there's agreement to all of that and implementation happens, then we will revert to the progression of people and implement that.
Remember to say that the wage negotiations, getting the resources and paying and all of that was very delayed. That's why towards the end of the financial year, it was difficult to complete all of those processes. So technically, it was kind of just halted for 1 year, but to allow for the wage negotiations and all of that to come in so that we can actually correct it going forward.
Thank you, HOD. Members, no more further questions.
No question, Chair. No question. I just want to ask you, Chair, if maybe you can make an announcement for Aircon. I thought I'm sick here alone. I can see even across that jackets are getting pulled off. Even no Monday next to you sweating. We can't. I'm going to collapse here, Chair. Please, can we just get assistance? I'm weak now.
Thank you, Member Barnes. We'll request, we know it's a centralized system. And when we came in this morning, we said we are so blessed today to not have extreme circumstances, but it seems like later in the day it's getting hot. Ms. Burgess, is it possible for you to please check whether the heat can be turned down? Thank you very much. Honourable members, thank you so much for your valued contributions and input. We will then further deliberate on the report and make some recommendations and resolutions accordingly. Can I please get an indication if there is any member of the public, perhaps a member asked your question and it was perhaps already answered by the Minister or the Department? Is there any burning question from any member of the public present? Can you let me just check? Is it 4 hands? 5. 5. Okay. Can I also just please ask that I know coming from the community, there's many challenges in some instances, and you would want to carry over your challenges as best possible in order to get the desired response. But can you also just keep your question or your input to the point, please? Sir, you may continue. Just put on the mic, please, sir. You can bend it down so that you can speak into the mic.
My name is Dion Carlson. I'm a human
Dion
rights activist.
Carlson.
Yes, Carlson. I'm active over the whole province in the West Coast region. My concern is I have several complaints here right in front of me where I have issues with ambulances. Last week on the 9th. Okay, let me leave the 9th. On the 18th. On the 18th October at 11 the evening, I call the ambulance. The ambulance did not pitch. I dial 112, I dial 10177, I dial 10111. But anyway, the ambulance did not pitch. The person, it was my neighbor. The person passed on around 5 the morning, the next morning. The ambulance arrived only at 8 a.m. the next morning. 9 hours. I'm waiting 9 hours, the person passed on the 6th hour while we were waiting. That was one case. I have the reference numbers here. And then there's another person, this was in Easter. Then there was another person that passed on at the hospital in Veldrif, Laiplik, the previous Friday. And then I have, on the 9th of October, I also called an ambulance. You wait for an ambulance 2 hours and onwards. I call even the paramedic, the fire brigade, nobody picks. And you've been told even when they put you through even to 1011 or you call for the fire brigade, and they will say there's no paramedics, not all fire stations have paramedics. And then there's this hospital issues where people went under operations and they've been sent home, and that operation places is septic and the people passed on. I mean, for me, this is really not on. And then what I want to know is, if you are on the Cape Flats, you call the ambulance don't pitch. If I will stand here now, I can prove that, and I call an ambulance now here in town, an ambulance will arrive within a few minutes. I can prove that. I know I can't call an ambulance or whatever because there could be a real emergency, but I can prove that. And then yesterday there was a report in the newspaper article that the department was sued for how many millions. Yeah. I don't see those type of things in the budget. And then I don't see how GBV and police brutality, how that infect even your budget, because people will be assaulted and they will have a J88 form and then they have to go to a health facility. You see where I'm going to with this? And then even with GBV, there is just no ambulances, there's no resources, especially in rural areas where people will die in Laiplik, Veldrif, and they will call an ambulance from Vredendal. And if the ambulance comes and the person is serious, they will bring the person here to Somerset Hospital. All those type of things. And when that person is charged from hospital, then people have to pay a private car to come and fetch that person. for me, this is really not on. Because on the ground, the people will call me. Sometimes I don't know people in the rural or West Coast region, but because they know about my things, what I do, they read on Facebook, and they will contact me. So for me, what I hear now is not really what happened on the ground. On Friday, there was an accident here next to a pedestrian was knocked over. Within a few minutes, there was a fire truck there. There was 2-3 ambulances. There was private paramedics. There was police. There was law enforcement. There was traffic. But when you call from the Cape Flats, you don't get that resources. So for me, even to see on Saturday, 3 ambulances parked at UCT and at CPUT, they've been used as vaccinating taxis. For me, this is a resources that has been not used properly. Because when you call from the Cape Flats, you've been told there's no ambulances. And I mean, for a person to pass on, you're waiting for 9 hours, and the ambulance don't pitch, and the person is dead now. The day after tomorrow, I will be there by that family. There will be a memorial service. On Saturday, I will be a pole carrier or a pole bearer. So for me, how can we sit here, the people from the health department or the health sector, and don't address this type of issues? I have to go back because I asked to be here, asked to have a chance to speak. I must tell a wife, a mother, a child that the system failed their dad, that the system failed their son in the West Coast region.
Mr.
I mean,
Carlson?
this is really not on.
Thank you. Sir, unfortunately, I will have to stop you at this point. Mr. Carlson, it seems like you have your incidents well documented.
Yes.
Can I please ask that after the session, you perhaps engage with the officials of the department and hand them over to you, because the incidents that you make mention of, the department, I'm sure, will not have the answers to exactly what happened in those cases that you mentioned. But you can respond, HOD, on what you feel fit you are able to respond on now. And can I also just ask if there are similar cases that members of the public will be referring to? Let's rather make a ruling to hand those specifics over to the department in order for them to look into it. We will also ask for the standing committee, since it was raised in this platform, to be held abreast of the response back to you. But for us now to unpack those individual cases, and the department still have to go and see as to what happened in what instance, will not be possible at this time. Is that in order with you? Thank you very much, Mr. Carlson. The sir next to you.
Thank you very much, Chair, to give me the opportunity to speak. I just want to, I don't know if it's a comment or a question. TB seems to be on the increase desperately because of the social economic situation that our youngsters been on drugs and all that. How do we get those community people, those youngsters, to the facility? Because it's very difficult. They won't go to the facility. They won't go there because due to circumstances, I don't know what it is, but it's difficult to convince them they need help and they need to go to the facility. The second one was about disability. I don't hear people talk about disability, and my concern is there's so many disability that can't reach the service that they really want to reach. Because 2 weeks ago, I visited Grootskio Hospital, and I was very upset because I got to the outpatient and I handed in the card for the disability person, and they referred me to, I said, I need a wheelchair. I was going to see 19. Now, I don't know the hospital at all. what the lifts, the channels, and where you have to go to C19 or 17. But in fact, I went to the porter myself. I spoke to the porter. They said I must go down to P4 with my car and take the disability person there. When I got to P4, P4 still had that big site for COVID, not utilized at all. We now finished with COVID. I'm not quite finished because we know exactly COVID is still running around amongst us. Yeah. So my question is to the security there, because they didn't want me to park there and to get, the porter is right behind on P4. The porters is right there behind the securities. So for me to get a wheelchair, it's easier for me to get to C17. But it was a whole rigmarole for me to get this woman to get a wheelchair and get her to that C17, because they said I must go back to outpatients and they must help me at the porter's desk. And I mean, really now, because then I got frustrated because I was sending up and down. But anyway, I stated my point, and I said, I'm not leaving. They must get a wheelchair from the porter and take me to C17, which they did eventually. But I had to park almost outside P4's building. Now, I mean, the whole COVID site there's no cars parking there. There's nothing there. And still that site is still not being utilized. The other thing is this, I need to know about, now that we are done with this COVID story and the stages is gone and all that, is there still not stats where people are dying of COVID? Or is there still people using the facilities regarding to being vaccinated or being tested? Because I watch the TV 24/7 and I don't see any status or anything on the TV that indicates to me that it's still there and they provide a service for that kind of thing. I do thank you.
Thank you very much, sir. Can we have your name for the record again, please?
Oh, Leslie Andrew Sylvester.
Leslie Andrew Sylvester.
As in Stallone.
Thank you very much, sir. Those members of the public remaining, please refer us to the page. Ms. Kivitz. Sorry, ma'am, did I miss you? Please proceed. My apologies.
I said I'm not going to refer to the page. I just...
You have a general comment to make?
Yes, please.
Okay, you will just keep it short then.
But they can start first, then I'll be...
Okay. Ms. Kivitz?
Okay, seeing that the MPs were limited, I think I would, if possible, I've got a question on page 11. The under expenditure for a community. And then we've had situations in our facilities where there was no staff because there were no budget. So if we have an under expenditure of 273 million, is there no way that that money could have been redirected for the appointment for staff that has been a challenge in the reporting year? Then the page, that's on page 11, that's for the under expenditure. Then on page 12, page 13, under the new and approved activities, the telemeds. I think my concern is that very few people or community members were aware that that is a service that the department renders. So my question around the new or proposed activities on telemeds, what is the department's communication strategy to communities around activities like this that makes the community aware of how they can access their medication. So I think the concern during the COVID period was, and we've seen the defaulting on medication, was that people did not know how to access their medication in the period under reporting. Then I have a question on, I'm going to skip those ones because you're going to stop me and I don't want to be stopped now. On page 24, under the organizational organogram, there are 2 vacant posts. The one is in Cape Winelands, which is a very big district. How long has the post been vacant? And how soon will the post be filled, if not filled yet? And the same under emergency and clinical support services. The clinical service improvement is vacant. How long is it vacant and when will it be filled? Then on that same page, I see under Dr. De Toey, and it's just, I think, just a concern because I was aware of the challenges in the Khayelitsha district at the time, is that we have Dr. Karva as the Director for Facility Management. When was the position filled by Dr. Karva? And with the challenges that was in the public domain, how was that appointment made? Then on page, I'm going to go to the children. I'm going to leave all my other questions. The child mortalities for children under 5. Now, I'm not sure if the portfolio committee can remember that I would always ask, if deaths are preventable, why are we not preventing it? So the deaths by children under 5 are preventable deaths. The department had a program that worked. And myself and Dr. Klute had the discussion in 2019 around community IMCI. So it's the community integrated management of childhood illnesses. And if the portfolio committee would do research, MP Plato, we would see in the previous reporting years, children's deaths were not as high as it is now. And yes, there is contributing factors, but there isn't a program and system in place where children in homes are picked up. Because when the community health worker goes into the home for a bedridden patient, she don't really see the child under 5. There could be children under 5 in that home, but it's not seen. So for me, the answer to the challenge around the child mortalities we have currently is my request to this portfolio committee to ask the department to please bring back community IMCI. It has worked. There's proof that it has worked. And since it's been taken away, we've just seen the escalation of infant mortalities. Then the state mortuary, I don't have the page number, but the state mortuary, do we really want our people working at Salt River Mortuary to work under those conditions that they are currently working? It's in the reporting year. What has happened to Observatory? It would have opened in the year of reporting. What is the delay? Where is the delay? And how can we just make life better for our officials at Salt River? Because their working conditions are not conducive.
Thank you very much, Ms. Keats.
Thank you.
The ma'am at the back. Yes.
Thank you, Madam Chair. Okay, I'm going to mute the other questions I had because the other members have already mentioned. First of all, before I raise an issue that I really would like the department to actually get attention of is to firstly start off with a compliment. I do want to compliment the department about Grooteskiel Hospital. You did a great job. There's quite a big difference from what it was before. But I wouldn't say the same with Khayelitsha as it has been mentioned earlier on. I'm not too sure what it is the department has in planning, in changing the situation in that Khayelitsha hospital. Now, I'm not going to leave out the other areas as well, which I'm going to classify as Black communities, which is Yonyanga, Philippi, Vanguard, KTC, and I think I mentioned those, and Mitchell's Plain Hospital. So I'm not too sure what plan the department has to upgrade the services in those areas, because more than compliments, we have complaints. So meaning that the community is somehow not happy with those services. Now I'm going to rubber stamp on one of the mentions that Mr. Arendse has alluded earlier on about GBV. I personally work with GBV victims every day of my life. Now I need to take victims to the level of the clinics or hospitals up to court levels. So when I get to the hospitals or other clinics, there's serious issues that we need to attend to, especially with how the nurses get to attend to these victims. So I'm not too sure if there's any plan as well that the department has in terms of sensitizing gender-based violence in our clinics or hospitals. Thank you very much.
Thank you so much, ma'am. The lady at the back, your comment?
Enkosi kakhulu umhlali ngaphambili. I'm going to talk isiXhosa because yona nto ndiyivayo. Are you ready?
I'm ready.
Enkosi kakhulu. Ngexesha le-COVID, kwii-area zethu zonke bekukho i-vaccine taxi, ne? And i-vaccine taxi ibisenza amanani aphezulu ukuvaccinate abantu abakwiindawo ze-informal settlement, abahlala kude nee-facilities ze-vaccine ebezibekiwe ngurhulumente. But aba bantu khange babe nee-challenges zophinda ziyokwenza i-GP yesibini. But ufumanisa uba ngoku aba bantu bayacomplaina nge-health, ngee-issues ze-health yabo ukuthi andiziva right ngoku, andazi noba yilaa jephu ndandifumana ijephu yokuqala, because khange ziphinde zifike ezaa teksi kwii-areas zabantu abahlala especially kwi-squatter camp nabakude kwezaa ndawo bezibekiwe ngurhulumente. Ithini into ke ngoku yokuthi umntu ofilisha into yoba aphinde eze, aze ke ngoku urhulumente ancedisane nabo bantu? Okwesibini, kwindawo yase-Atlantis ndifumanisa into yoba ugqirha omelana ne-mental health issues uyi-1, but indawo yase-Atlantis ine-population engapha kwe-200 and something thousand ngoku. And laa ndawo esasibhedlele sapha e-Atlantis sasakhiwe in 40 years ago. I-population yayingekho ngaka ngoku, including ngoku kukho nee-national foreigners esingazazi ukuthi zingaphi inani nazo, but ezi also zibhenefitha kule population siyaziyo yase-Atlantis ukuthi ingakanani. Sicela ukwazi ukuthi bona khona besuka ngaphandle njena aba bantu, ingaba urhulumente unayo imali ebekelwe i-national foreigners ukuthi nabo babhenefithe kula mayeza anqabileyo kangaka kule ndawo yethu yase-South Africa? Okwesibini, kukho iityhu ezinde kwiindawo zethu kwesesibhedlele. Ufumanisa into yoba xa uzoya kwi-appointment yakho ufola ngaphandle kwesibhedlele, akukho shelter, akukho ntoni. Sicela ukuza into yoba asinokwazi uba sincedwe na iipeshenti zethu ukuthi kubekho i-cover shelter ukuze bangathi besiza kwemthwalampilo baphinde bakhetshe ingqele nelanga. Okwesine, Ndicela ubuza uba ayikho na into yoba eza kliniki naniziboleke uCity of Cape Town nizithathe back ngoba asoneliseki nguCity indlela aziphethe ngayo ikliniki. Umzekelo, kwindawo yaseVetsanti, ikliniki yapha yi-mobile clinic. I mean, what you call temporary clinic as a Tuesday and Wednesdays, and it's falling apart. It's not even cleaned thoroughly, and it doesn't have a lot of izinto ezinodingwa ngabantu ngabaze emtholampilo. And ayenzi yonke imihla abantu ke ngoku sifilisha into bingase provisional government ayithathe back la clinic kuCity ukuze nathi sikwazi into yoba sibe nazo eza wellness hub zenziwa ngabanye abantu kulaa ndawo yethu to minimize aba bantu bahlala kwesa sibhedlele esincinci sase-Atlantis esiyityhuzayo zofike zisuka kulaa i-distance ungalifolisha i-distance engange-100 kilometers. Yayibona into enjalo? Ndiyayicela kwakhona nilapha kule ndawo abantu aba-bed driven. For example, ndinomntana oye-involved kwi-car accident ngo-2019 akakwazi kwenza nto kuba i-injury yakhe ilapha entanyeni akakwazi ukufumana nix. Ngoku into enzekayo umzali wakhe akaphangeli and kwayena lona imali yakhe yile 1800. Xa izoya kwifizio uyaxelela uba idate yakho ingexesha elithile afike ugqirha engekho. Xa ifike engekho laa mali ibiqeshe itransport ayisasebenzi ngoku ngoba laa mntu uthathe itransport wayithini wayishiya endlini. I mean wahamba wambeka nje esibhedlele afika fa ugqirha akekho kodwa benzelwe i-appointment. Yenza kanjani into yoba ubekelwe i-appointment wawugqiba ugqirha angabikho owefizo? Ngoku laa mntana uendaphe yena esenzani engayi kwasesibhedlele because imali ayikho. Senza njani singurhulumente ukuthi sincedisane nee-families eziphuwa ukuze zikwazi mhlawumbi itransport ye-state iyomthatha laa mntana ukuze abe bhetele kwintlalo. Imagine umntana ona-22 years oyeke ufumene i-car accident esenza ugrade 11 kodwa ngoku endapha eluza ukuthi makaye esikolweni afunde ukuze abe yile nto ebefuna uba yiyo. At the same time kukhona nenye i-issue endiqomba indenza ubuhlungu. Intombazana eyenzelwe i-operation for i-appendix wenze i-operation then wapregnant ke ngoku last year. This year in July wayabeleka wazobelekela apha eSomerset. And instead of bamenze la cesarean operation incinci bamenza on top of la operation abebeyenzile wayenziwe la operation and up na 3 operations in one place. Wagula ugula kwakhe doctor wena Dr. Noma French laa mntana ngoku unestroke ujijeke umlomo wakhe sowukule ndawo ngoku ngoba uyastressa. Sibanceda njani ukuthi oogqirha benze sure that ii-patients abazirelease zingakhange zitshekishwe ukuthi le operation yenziwe kulo mntu yi-operation erayithi engazuba ne-side effect endaphe ugovernment wethu ebekwa kwindawo engeyiyo. Okwesine le ndawo yeambulensi yase-Atlantis iyadika. Ambulance ezimbini ekubeni Atlantis ininzi kangaka siyi-2 qha iambulensi zase-Atlantis. Ufowuni endaphe uhayarisha eyakho imoto. Ndithi ke ngoku ndiyacebisa why kungake kuthathwe mhlawumbi a certain taxi owner or mhlawumbi certain individual anikwe ipermit yokuthi xa kukho i-issue kwi-area ethile mayithathwe le transport is permitted to take these people bamse emtholampilo and then abhale phantsi yena asubmite kwa-health. That is just i-proposal. Okwesine ithini relationship.
Ma'am, I will unfortunately have to stop you at this point. I can also see that you also have your challenges well documented, and the same will go as with Mr. Karels as well. Please do make time to engage a dedicated official.
Just a small one.
No, ma'am, please give me an opportunity.
Just a
and then
small
hand over those issues that you have. I do also want to urge you that please do not wait another year for us to have this session to speak to the issues that you are raising now. It's serious concerns that you have and incidents that have happened. Please make sure, and I'm sure in the departmental response, of which I'm going to give you a rough, I can give you about 7 minutes to respond, and perhaps after the session you can engage with the members of the public. But I'm sure, and I would want the department to also give through the channels as to which you can immediately raise those issues that you have and not wait until we come to this session. As much as we are very much appreciative that you did come today and you did raise it, and I'm sure there's going to be an opportunity after we have concluded this business for you to still engage some of the officials on that. Thank you very much. HOD or Minister, 7 minutes. Meneer?
Baie dankie, Voorsitter Lindors is die naam. Thank you for those that reminded the chairperson that I still need to speak. Chairperson, I
did not see your hand.
I will not be able to give you the number of the page because I haven't concentrated on that, but I'm going to look and talk about the client satisfaction survey that was spoken about. Now, I know that the response was that, yes, we did it. It is a correct indication of what is happening. But our concern as a community is that if the satisfaction rate is so high, why do we still have so much complaints that's coming through? It tells me from the community side that whatever or whoever is doing the survey, and I think that is the question I want to ask, how is the provider for that survey selected? Because it tells me that whoever is doing that survey is not doing something right, because if the person was doing something right, things would have changed. Because it's not issues that there is only coming on today or only now. It's things that are there every day. And then I would want to ask, how was the sample determined? And as I said, the satisfaction target reach is not speaking to the realities experienced at the service center or on the ground, as I say. Are we doing the survey just to have the satisfactory answer that we want? I think that is my impression, and I would like the department to respond to that. But let's respond, Chairperson, honestly, because our people on the ground is feeling the poor service that is there. And I can go and I can talk for hours in terms of the poor service, and it is issues that I raise with the department, and the department at times doesn't care to come back. You would mail them, they would not come back. They just don't care at times to respond. And I've got proof for that, should anyone want one proof for complaints that I've lodged and hasn't been. So in terms of quantifying what I'm trying to say, Chairperson, is people are dissatisfied with this service because they're spending long hours at the facilities. It's something that's coming on for years now. There are people that are being turned away because they are told that they're busy fumigating. I unfortunately lost my sister through that. She went to a facility on a Friday afternoon to be told she had a stroke, to be told no, there's no help at the moment because they're fumigating. I had to phone people because luckily for me, I know people that know people that know people, and just because I know people, I could have phoned people. The question is, what does the other persons do that doesn't know people who know people who know people? That is what's going on. You would get in facilities where clerks tells people to go to a certain room. When they get to the room, then in that room someone decided, no, we're not taking these people anymore. Then they are being redirected. People that are already sick. And it's not because you go to a facility because you enjoy going there. It's because you're sick. Now you are being sent from pillar to post. That's the realities that is being felt on the ground. We experienced, Chairperson, in this year during the winter period, a facility that was closed because the roads was flooded. I could not understand. I asked that health committee, because there is a health committee that is appointed. I asked that health committee chairperson, how on earth can you allow a facility to be closed? And then that facility tells the clients to go to a nearby facility. Now, if the roads are closed because it's flooded, for your workers to come into the area, how can you expect the community that is sick to take a taxi with money that they don't have to go to another facility? And that's the lived realities, and I can go on and on. So I would want to really understand, are we doing a survey that is giving us the results that we want, or are we genuinely doing a survey that will assist us? Because I am of the view that you do a survey to improve the service. That's the question that I want to yeah. And the health committees, I don't see them. What is the status of the health committees within our facilities within the Western Cape, Chairperson? Thank you.
Thank you so much, sir. I'm going to start with the Minister. Minister, we are adding some time for the entire response, 10 minutes.
And it's 10 minutes for all the questions.
Yes.
Okay, then I'll respond generally, and then the department can do the specifics. And I'll just do generally that I think I'm repeating myself, is that the platform or the sector that caters for the whole population, from the unborn to the oldest, including the deceased, 24 hours, 7 days a week, 365 days a week. And you get a platform like Tigerberg where you easily can get thousands of people in one day, not even 24 hours, in one day. You are bound to have some of the challenges that you are indicating without necessarily justifying. But the point that I'm trying to make is about there will always be some of those challenges. But the question for us is about how to make sure that in a bag of apples, in order to prevent all the apples to be rotten, how do you identify that apple that's nearly to be rotten and take it away so that it doesn't spoil other apples? So that's why the system in place, like the hotline, so that you don't wait till longer when you have got that challenges. 2, it's about how do you make sure when we err, we are able to admit and not dismiss what has happened, and things can be able to happen. So I mean, to be able to correct it so that you don't have a repetition. So the hotline of the 0860-142-142 is part of it, that you don't have to wait that I want the Mbombo's number or HOD's number, and then you wait till longer. Please call me the 079 number, and also the email service at Western Cape, especially when you want to send all these photos. These are part of the Western Cape government hotline, so that immediately those things happen. The process is, it's about when we receive those, where they are being received, they could be directed and diverted where it's relevant. For example, if you are complaining about the experience in Khayelitsha Hospital, immediately the CEO of the Khayelitsha Hospital, if you have provided the details, they will call so that they can be able to hear you and then find each other. So that makes it easier, rather than, for example, for us, probably for me, it might be easier, but for government, cannot be when things are posted in social media. Mr. ABC was at this hospital and the patient has got photos there. Confidentiality and all of those, you have to avoid those. And also, when you have to only to call me about it, or to call Dr. Kluto, any of us, we won't be able, because there must be investigation. What happened? Why was that? It took 10 hours or whatever for the ambulance to come, because I might sit here and say that, oh, it won't happen again, but I don't know what happened. So that's why it's crucial to use those kind of the processes around that. So indeed, we will always be have some of the challenges and we always err in other ways, but how do we make sure that there are lessons learned, and also how to make sure if indeed someone did something wrong, that person needs to be dealt with accordingly. But the issue is about when you say that the whole of that hospital, they are racist, they are rude, I cannot pick up a phone and say that you, all 600 of you in Tigerberg, you are racist, you are rude. They'll be like, really? After we have worked, because there are many people who are dedicated, who work so hard. So that's why it's crucial that we focus on some of those people that have dealt with a part of that. But generally, Mamun Bomb, she's a bomb. Mamun Bomb, the issue of the West Flare, you know that part of the task team, they are being dealt with. We don't have to go deeper in terms of that. But what I know that I'm going back there again to reassure in regard to the wellness hub, which is actually the way forward. That we need to have wellness hub, but now integrated, not only the vaccines, Vexitaxi, but also other parts component of the special to strengthen the primary health care. The Vexitaxi is it's not necessary that they are using the fully fledged ambulance. It's like a panel van, sort of. They put gazebos outside. So it's not about they're taking an ambulance that's supposed to be going and fetching the people. It's like a mobile clinic, but it's because it's being managed by the EMS. I think the other parts, Dr. Klutu, because Mamu Ukivi stated clearly in terms of where are the page numbers and all of those. But just in closing that, I did go to Salt River to check in terms of the progress related to the new forensic pathology services. It is got to do with the service provider. And if we didn't have our staff who are so skilled, who knows what they want, would actually have probably allowed to take over a house that has got cracks, where later on you find that there. So when I was there, you'll find that they will say this table or stretcher doesn't even go up and down. It's like, actually, sir, even my height is above there. So no person will be able to conduct postmortem in those kind of areas. And the others where the fridge is, where you can't even open the fridge, it's down locked. So it's those kind of things where they've got that eye, say that, no, we have got these nets, we won't be able to take things like that. Over to you, Dr. Klutu. Thank you.
Thank you, Chairperson. How much time I have? 2 minutes. Okay. No, so I mean, firstly, just to the colleagues from the community structures, we appreciate the feedback. And part of which I think is quite an important thing for us to do is to create avenues for being able to listen to people. I think it's unfortunate that once a year in an annual report session, that the colleagues are saying, so what I'm hearing, what the colleagues are saying, they don't have appropriate places where the issues can be heard. So what we need to do is actually create the spaces where we can create listening forums to people. So we'll ask you, we'll come to you, we'll reach out to you, and to say, how do we create a place where your issues are listened to and your issues are heard? Because at this place where we sit here, the general issue is somebody that has a bad experience in a healthcare facility is obviously extremely bad for that person and for that person's family. It's very difficult to relate that individual experience to an experience of 17 million contacts in a year. So when we talk at this level and we engage the committee, we talk about what is the average of what happened over the 17 million contacts, not on the 10 individual bad experiences. It doesn't make the 10 individual bad experiences any better. So that for me is the take-home message of that. So every individual experience, as you rightfully said, and the minister said, we encourage you to take the individual experience, document the detail for that individual experience within 24 hours of it happening, and register it on our platforms. use the platforms, because if you registered, it becomes part of the system for us to respond. So that will just be my appeal for everyone. The specifics, if I go into the specifics, I would say, Mr. Carlson, the specifics of EMS, it would be good for you to actually table that specific incidents, one by one, individual, who's the people, what's the name, if that is the detail you have, please hand it to Dr. Karim. We will put it into our system and somebody will come back to you and respond on each individual thing. As I said to the committee, I take pride in the department. When those things are registered, people take the time to respond to them. Mr. Lindos, of the examples that you say that if you have seen, nobody responded, give that to Dr. Karim. So you can see when did you respond, who didn't respond, so that, because we take that seriously, where somebody makes an effort to register individual details so that we can follow it up. In terms of the medical legal payments, Mr. Carls, you might have missed it, but Mr. K did refer to the medical legal payouts. That article that was run yesterday speaks about the amount that was declared in this book, and in the annexes, all the details are there. So that is part of our disclosure, and that is part of what Member Barnes asked in terms of what is those payments to households. And the detail is in the book. The reason it's in the article, we released to that journalist exactly what we're releasing to the public because it's in the public domain. So in terms of TB, Mr. Sylvester, I completely agree with you. It would be important for us to walk a path and a journey with yourselves, because engaging young people and understanding what makes young people use health facilities would be so crucial for us. But it won't just be for health. We need to do this for education, for DSD, for everyone. And really, if we want to do one thing through that ABT structure, which I explained to Mr. Lindos, will come to your areas, because Klipfontein is what we want to do. It is really walk a path with you to say, how do we reach the young people? As health, we might not have the answers. We might have to ask DCAS, sports organizations, whoever the young people trust. We must go and actually sit down and I find out from them what is it, the things that actually keeps them. But for me, that's a very, very crucial thing to do. Your experience with the disability is unacceptable, and that's an example of a case which you have quite detailed, to give that detail so that we can give you exactly what happened and find out exactly what happened so that it doesn't happen to the next person in terms of the system. And then the COVID stats, it is available. Dr. Moody sends it to us every day. I think people got tired of the stats. But if you're interested in the stats, we can make it available to you, and whoever's interested, we can give it to them on a daily basis to tell you what's happening with the stats. Ms. Kivitz, yes, the under expenditure for the 273 was explained by Mr. K. Your question was, should that money not have been redirected to pay for staff? My answer earlier to Member Windvogel was, in there lies a complication, because staff that's needed, it's again against that which staff is actually paid against that facility versus which staff are not on duty on that day. And if we are making people to be paid out of this under expenditure, what is the carry through of that staffing in terms of that? But I think it's quite important for us to understand that we deliberately, intentionally, and we're one of the only departments that's doing that with our provincial treasury, we deliberately, intentionally take certain amounts of money. And if you take 273 out of 28 billion, it's a small amount. But what we do with it is we smooth out our pressure for the year after. So they know what pressures we're going to face next year. So there's an intentional process of saying, use that marginal amount of money and not just spend it on anything. Make sure that we are less in trouble next year. And this carry through is a very important thing. And we obviously can do that. The telemedicine communication, I agree with you. We should be having communication, but the telemedicine specifically that's mentioned here is specifically for diabetes patients and specifically for TB patients. And these are individual patients known to the provider. So people that have been getting this service would have gotten a call from the healthcare facility. We know specifically a very interesting pilot, again, happened to be in Hanover Park. So when we have that detail, we can tell you how diabetics have been called in Hanover Park and they haven't had to come back to the facility. And it's very, very interesting and very, very good results that we're getting in terms of the care for the patients. But again, that detail we can make available to you. I agree with you around community IMCI because you and I are both passionate about it. Your estimation that child deaths have gone up, we might have to wait for the annual, what happens to the under 5 mortality over the last 5 or 8 years. Actually, generally, under 5 and under 1 mortality has decreased over the last 5 to 10 years. We are expecting a blip in 2022, but 2022 is not completed yet. So we'll see next year what happens to that. And we'll also look at the causes of that. But the concept of community IMCI is a crucial concept. And I think from the conversations that we had here, it's important to go back into that community-based healthcare worker offering to look at how do we support households with children under 5. So I think that concept and what was raised by Member Plato as a whole of society, that's an ideal vehicle for that whole of society vehicle for caring and looking after children. So I really think we will take that very seriously as a policy consideration. I think the Minister answered the Salt River issue. And then I think the other questions about Atlantis, Sky Litcher, all the other services, I think that goes into the broader comments that we've made. Just for Mr. Lindors, the client satisfaction survey is done by every health facility, and it's done in November, and there's a survey methodology of asking the people that's in the facility to fill in a survey. Now, that is the people that's in the facility. Now, I must say to you, I again hear the reported cases of people having a bad experience, right? So we all know it, and we hear it, all of us hear it. I do visit health facilities. I can tell you I walk through the passages, and I talk to people in a health facility. And I can tell you overwhelmingly the health facilities I've been to, when I talk to the people sitting in the facility and what the experience is, overwhelmingly people are having a relatively good experience. It doesn't take away from the fact that the ones that we hear complaints about is people say, this happened to me, that happened to you, that happened to that. But you have to realize, I mean, in a place like Mrs. Plain Day Hospital, Community Health Center, there's between 900 and 1,000 people every day. Now, 5 people have a bad experience, it's bad. 5 people had a bad experience, but it's 5 of 1,000 that has it. So we really need to understand scale when we talk about adverse and negative experiences. And we're not negating the negative experience. We put it in the context of the scale of the numbers that we're dealing with. And then I guess, as you rightfully say, it would be important for us to come back and say, where's the statutory bodies? What's the status of the statutory bodies? How do we engage statutory bodies? And how do we base community settings and community formations outside the statutory bodies in terms of creating the listening places? That's something that the Minister's asked us to do seriously look at in here, and we will take that forward as part of Health is Everybody's Business. Thank you, Chairperson.
Thank you very much, Dr. Klute. Minister, any closing remarks from your side?
I think what is crucial is about when we come back now with 2022, not as an ongoing, as part of the, whether it's a quarterly report or is part of the performance, it becomes easier because now we're dealing with things that happen until 31st of March 2022. So it becomes difficult. I think the issue about what are the lessons learned and also to compare what we're saying now to what we have implemented, the lessons that we have learned from then, that will be crucial about it. And probably, Chair, just in future, we need to explore. There was a time when we started with the budgets, when we go to budgets, when we were budget to the people and then they make an input at the standing committees. And then probably what we should do as well is about when we do the budgets, and then afterwards, when we do the annual reports, we just have some of the groupings where we can share with them, because there's a smaller space now that they have to just fast track. And also some of them, they still have to find out whether they must ask for the question, is an opportunity to ask the questions now, so that they could be able to take it to the communities on to find that those questions are for now. We were talking about things that happened last. So there's some of the things that we need to explore. Yes. Thank you very much.
So
and
much,
thanks
Minister.
also to the department, because I'm aware that others won't be here for the scope, they might be online, but I just want to thank everyone and also to the members for everything. Thank you very much.
Thank you. Members in a hurry. Anything from your side, HOD?
Thank you very much, Chairperson. So I really want to thank the committee members. I think we did have a very good relationship over the years. And I recall my last appearance with this committee, I burst into tears. And that was when we came out of COVID. And I really want to say for the relationship between the committee members and our department, we're really thankful for the supportive manner in which you bring your role to bear, but the way that you engage us and the way that you actually are fair in the way that you raise issues and how you raise it with us. I really want to commend the committee for that. Obviously, for all the staff members to the back, I won't burst into tears today, but just to say to all of them, I mean, these are just incredible people that work in our department. I am every day when I engage, when I visit, when I go, I just come home and I just feel humbled by the dedication and the commitment of the people. And people really care about their works. Everything is not perfect, but commitment and dedication and ethics, and you can't find a better team of people. I'm really, really fortunate to work with a team of people like this. And to our community members, we feel your pain. We feel the disadvantage, that the areas where you come from and where people experience healthcare services in a certain way. We will never, ever minimize that. Our healthcare system is based on the fact of dignity. And until every single person has an experience of dignity, our job is not finished. But we're willing to walk that path with every single person to restore the dignity of everyone in this province. So thank you for raising that with us. Thank you.
Thank you very much, Dr. Kloete. And I think from the committee side, as much as alles is nie altyd maanskyn en rose nie. We've heard about the challenges that the community that they occur on a regular basis. And thank you, Minister, again for alluding the fact that there are channels within the department where these issues can be raised, and also going forward as to how more can we include the community to become part of the processes, not just when we at this point looking back on a financial year, but actually becoming more involved in the processes going forward. I think we have to, at this stage, also commend the department for the wonderful work, Minister, you and the team and Dr. Kloete has been doing. Again, a fourth clean audit outcome, and the first and the only in this country that is it's commendable. It doesn't happen every day, and with that, one can only imagine what, as you said, commitment and dedication goes into achieving that. But it doesn't take away the lived experiences from what the public has shared with us. But as I said, as Minister indicated, do bring those matters under the attention of the department. It's also commendable, Minister Dr. Kloete and the department, that 99% of the equitable share was spent. We have to give credit where credit is due. And it's also very, when at the time where we experience a national energy crisis, where 75% of facilities have reached the energy consumption benchmark, it's indeed commendable. So not all is bad. There's still a lot to do, but we need to give credit where credit is due. So from our side, thank you very much for the sterling work that you have been doing, and please do continue. Members, thank you very much for your indulgence and the wonderful and productive and valued inputs that all of you have been providing. Ms. Namonde Jamke, our very capable procedural support. Ms. Burgess, thank you so much for your patience as well. Members of the public, much appreciated, and we really do hope that we will see you on a more regular basis. And from our side, we will ensure that we extend those invitations far and wide to make sure, and also that we have enough time to engage with you as well. So thank you so much for coming all the way today. This meeting is now officially adjourned. Thank you so much. And you are most welcome to enjoy lunch in the members' lounge. Thank you. Members just need to stay behind another 5 minutes, members. I can't kill myself.
But this is not high. That is not high.
No, it's not, but it's very tight still.
Tight.
It hasn't been walked through. So I don't want to go through this today.
We have not seen Dr. Peter for quite some time.
But yeah, he's also chairing two other committees. That's why he doesn't want to, there's nothing to do with us.
Hi, Doctor.
Dr. Kloete, goed gaan. Yes, absolutely.
We need to hurry, otherwise those that tested, you are still attending the scope here.
Yes. Member Barnes, Member Barnes, Member Barnes and Member Van Vogel. Can you please excuse us? Thank you. Members' recommendations. Member Van Vogel. Get the mic, please, members.
Thanks, Chair. I just want to, I'm not sure how are we going to put it, but the whole of remembrance. It was an issue that was discussed in the previous annual report, and there was some commitment from the department side through the HOD that we will have. So if we can get an answer, I couldn't ask. It's like Member Plato was saying, we have so a lot of questions, but we have to choose what are we going to ask. So I really want to know from the department what is their plan in terms of that whole of remembrance for our fallen workers. Health workers. Then secondly, Chairperson, also if the department or department must provide more details on the, remember I asked in terms of the ambulances per district. I didn't want to ask a follow-up because our time. They didn't give me an answer in terms of district. How many ambulances do we have per district? So if we can get that information. And then lastly, Chair, if we can get more details regarding the funding model in operation for district and the regional hospitals, because the minister mentioned something about, I'm not sure if it was the HOD, the cost to convert a district hospital to a regional hospital, there's a lot of cost involved. So if we can get a picture of what the cost is, if we can get more detail explanation on why is it not feasible for the KDH to be converted into a regional hospital. Thanks, I will park there, Chair.
Thank you very much, Member Barnes. Thank you, Chair. I only have two. One was on the question that I was asking on the benefits of the NPOs, the NPOs that benefited from there was this, I don't know how to explain it, but NPOs that were listed that seem to have benefited. But I think my question is rather that if they can give us a list of all those NPOs that benefited and their board members. Yeah, that's what I wanted to resolve on the first one. The second one was on the question I asked. NPOs that benefited from? Just check my question again here. Let me just check. Sorry, Chair. Sorry about that one. Okay.
transfers to non-profit institutions on page 90. Now, my question there was how these NPOs were selected, and then it was answered. Now, I wanted a list of all those NPOs that were selected and their, and their board members, the name of their board members. Then my second one was on the list of clinics that have received secure waiting areas, when I was asking about waiting areas, and then the response was that new clinics are getting already, you know, the secure thing that was, yes, the new ones, but the older ones, they are getting a structure, but it comes with phases according to the response. What I want to know is who already have these structures and who's next in line to get, if I could get a list of how many already have and who is budgeted for in the next phase. That's the two resolutions I want to.
Thank you, Member. Then Member Keho.
Yeah, Chair, mine would be in a form of an inquiry, man. I've noted, but it's just that the department did try to articulate why the reasons and citing a number of things, but I've noted on page 168 regarding the issue staff leaving the employ of the department, the rate is very high. For those who are contract workers, there's 2,227, and for resignations, it's 1,618. And I was asking them now about issues challenging to staff complements and in the department. If you take that, it's close to 4,000 people together, those who are contract workers. So if we can be able to have a retention strategy of the department on how to keep their staff in their employ, because that number is very high for a department that is complaining that it is understaffed and all this kind of thing. That what are they doing to?
I also wrote that down, Member, somewhere. I can't read.
Yeah, but it's just that
writing now. But there was also a quite significant amount of resignations where people did not want to indicate why they leave the department, and also a big component of young people. I think between the age of 18 and 34, something to that effect.
But you know, they are smooth talkers, these people. When they talk, you sometimes other critical things you just forget.
In terms of, you know, if the department have perhaps an internal program to make sure that they preserve those retention strategy, the same as you've indicated. Member Plato. Thank you. I see now I've left that question for Scopa, but I'll ask it in there as well. You can if you want to as well. I think my question, I only have the one question and or rather recommendation, and it's been coming up regularly in almost all our sessions. When the department speaks about a community-based approach, the issue of community-based workers comes up, but also their remuneration, you know, the stability within the sector. I would want to know, why is there a hindrance or hesitance on national level to deal with this matter? No, what is National saying? Can we acquire that information through the department? of community-based workers. Do you get what I'm saying?
I don't know if I'm
Yes. 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 And what, if I understand the department correctly, they speak about home base and also why wellness is in it to have that more community-based approach when it comes to health. So these corps of individuals or staff members will become even more critical. Yeah. But I, for instance, don't know what is the level of negotiations on national level. Why is it that they cannot become formally part of the department and fully enjoy those benefits? Because this is not, it's not in the hands of the province. It's something that's nationally negotiated. Yes. Yes. But they want to be permanent. They want to be permanent staff members,
Yeah, that was
as the rest of the corps. But that is not something that Western Cape Health decides on. Yes. Exactly. So can we please ask that they provide us clarity with?
Perhaps
answered.
they
Because
did.
they
The
mentioned
minister.
It's not clear for me.
See, what did you hear?
that it got matters to do with the bargaining chamber in terms of salaries and all that. It
The
has to do with
qualifications.
Department of Labor
Yeah,
and
but
all.
I need to understand what the process is. What is it that the unions demand? What is it that national government say they cannot contribute?
Where are they now?
Waar is die haakplek?
Waar is hulle nou?
Yes.
So, so what will be? How to write it down?
Progress on the negotiations. I will put it like that.
For the
Because there's,
permanency of
according to her,
community-
there's a progress. They are busy with negotiations, and our minister of them, they are also part. All the provinces actually are part of a certain process.
Yes, but there needs to be a decision taken.
Yeah, up
the
there
will
with
needs to be established
at the
there at
bargaining
national,
council. So
in
if we
order
can-
for them to.
We can get a report on that.
So that's my song.
Then
Member Van Vogel?
the last one, Chair, I must that is currently we are sitting with a problem with KDH Hospital. I want the department to explain to us what are they going to do with the current situation, not 2030 when the GST is going to be built. If they can give us, remember there was a request from KDH in terms of funding to assist to at least give the type of service that the Kailicha of surrounding people deserve. But from the department side, what are they going to do currently with the situation that KDH is experiencing?
Contingency plan. What situation?
It's the mental, it's the, all those the issues that was raised, the beds, all those.
The contingency plan. Yeah. So you have that captured? We have it all captured. Members, thank you very much. We see each other at 2 o'clock. It's Scoper. The meeting is adjourned. Thank you.
And it's good that we are bringing it here because sometimes. I don't even know. You don't even know. Are you guys four? Are you four?
Yes, 2 interpreters for
sign language. Oh, the sign language.
One for English and Spanish.
Oh, I was wondering. That's good.
No, you must keep it.
I don't know.
Oh, keep it. I'll tell him to fetch it for
But he must be here. Isn't it here? Where does he sit?
He sits where Zuki sits.
I don't even know where.
And Elvin.
But if you take it, it's going to fast track your payment. Because now I don't even know.
I'll take it to him.
I don't even know who's this. Jason? I don't know. I don't know him. Members Lounge.